Good morning. Good morning. Welcome to the Health Policies Commission's event focused on the workforce crisis in Massachusetts healthcare. I'm Deb DeVoe, Chair of the Commission, and on behalf of all the commissioners and the HPC staff, I'm glad to be with those here at Suffolk Law and also those on the live stream for the event. Welcome. Our purpose for this session is to examine the facts about the current situation with our workforce and to discuss and support a path going forward. We appreciate the legislature charging the HPC with studying the issues and producing a report, and will present our findings today. We're also hosting two panels of leaders who are at the forefront of understanding how workforce shortages are affecting us, testing responses, and advocating for policy solutions. We hope this contributes to our common goal, building and sustaining a robust healthcare workforce in the Commonwealth. I look forward to the discussion. I'll now ask David Seltz, the Health Policy Commission's Executive Director, to provide an overview of our agenda and introduce our first speaker. Thank you.
Well, good morning and welcome. I'm David Seltz. I'm the Executive Director of the Health Policy Commission. So pleased to welcome everyone here today for this really important event and an important discussion on, I think, a really critical topic that is top of mind for so many people in this room. There are a number of people I want to acknowledge and thank as we kick off this event. So please indulge me, continue eating your breakfast, enjoy that bacon. I first really want to acknowledge the members of the Health Policy Commission board that are here today. For those of you who follow our board meetings closely, and we encourage you all to do that, check us out on YouTube. We kicked off this year with a discussion of policy priorities. This is the 11th year of the Health Policy Commission, and we saw a real opportunity to reflect on the past 10 years and put forward a bold agenda for action. And included within the discussion for those priorities was addressing the healthcare workforce, challenges, and identifying solutions. And I want to say the commissioners were unanimously supportive of making this a top priority for the HPC's agenda this year. And we're very supportive of hosting this special event. I think recognizing that there is an intersection between healthcare workforce challenges and the HPC's goals to advance healthcare cost containment, health equity, and affordability in the Commonwealth. We're very appreciative of your leadership and support. So just to acknowledge the commissioners that are here today, Chair Deb DeVoe, Vice Chair Marty Cohen, Commissioner Blakeney, Dr. Castiel, Dr. David Cutler, and Commissioner Tim Foley. And we may expect Commissioner Berwick to join us at some point this morning as well. As you'll hear more this morning, alleviating the current healthcare workforce challenges will require coordinated, sustained, and well-resourced interventions in the short, medium, and long term. And that is why we're also pleased to have so many important state and federal policymakers in the room today. I want to welcome the members of the legislature who I see here today, and thank you for your support and partnership. Senator Sidney Freeman, Rep. Kip Diggs, and we are expecting maybe a few other legislators to join us as well. And finally, we do this in partnership and in coordination with the Healy Driscoll administration, and want to acknowledge a few people here today from the administration. We have Acting Undersecretary for Health, Karen Sung, Director of Healthcare Workforce and Policy, Patricia Yu, and Mary Beckman, Special Advisor to Secretary Walsh. Thank you all for being here. And finally, I do want to recognize our partners from other state agencies, Lauren Peters from the Center for Health Information Analysis, members of the Group Insurance Commission, the Attorney General's Office, the Department of Workforce and Labor Development, and the Massachusetts Healthcare Collaborative. I guess really finally, I do want to acknowledge, of course, the HPC Advisory Council members who are here today too. We also had an advisory council meeting at the beginning of the year where we talked about priorities for the HPC. And I kind of posed the question pretty open-ended to the members of the 32-member advisory council. And we spent about the next hour and a half talking about workforce. So it was clear to me from that conversation that this is a priority for conversation. And I think the importance of today's discussion really cannot be overstated. In Massachusetts and nationally, the healthcare workforce is in a state of substantial disruption. Today, the healthcare system is experiencing workforce challenges at virtually all points of the care continuum. A pre-existing challenge that has been deepened and exacerbated by the COVID-19 pandemic and is now impacting patient care. To inform today's dialogue and future policy action, the HPC sought to leverage our independent policy leadership and research expertise to bring new quantitative and qualitative insights through a new report that is being released today. This report, Healthcare Workforce Trends and Challenges in the Era of COVID-19, Current Outlook and Policy Considerations for Massachusetts, is now available on the HPC's website, and we provided an executive summary here today. One of our goals for today's event is to share our findings and recommendations for discussion with this broad spectrum of healthcare workers, leaders, and policymakers representing important elements of the healthcare continuum. Our report provides both an overview of some broad trends in healthcare as well as current workforce challenges and solutions for some select occupational groups within the healthcare workforce. So in this report, we focused on registered nurses, direct care workers, and behavioral healthcare providers, which comprise about 65% of the Commonwealth's healthcare workforce, and each of whom have experienced unique difficulties. In addition, recognizing that there are important workforce pressures and trends in additional healthcare sectors, the HPC anticipates future reports that will more closely examine additional professions such as primary care providers and in different settings of care, such as community health centers and ambulatory care settings. We hope to hear from you about what the priorities of the HPC's research agenda should be moving forward. But just as importantly, we hope to identify areas of shared agreement that will form the foundation for collaborative solutions and bold but necessary interventions into how we pay for and deliver healthcare in the future. How do we balance our closely held values of access, quality, equity, and affordability that are at the core of the Massachusetts healthcare reform journey? These challenges are real, they're significant, and they're interconnected. And the urgent need to evolve our collective approach is clear. We look forward to working with the administration and with the stakeholders today to address this challenge in the weeks, months, and years to come. And I remain optimistic that Massachusetts, with the will and shared commitment of many in this room, can blaze a path for the country. We have a great agenda planned for you today, and we are excited to get into the topics to start our discussion. As I said, we're first going to hear a presentation from the HPC's research team on our new report. We'll have a brief opportunity for some question and answer on the HPC's report. And then we're going to move into our two stakeholder panels. Our first panel will be moderated by HPC Commissioner and Worcester City Commissioner for Health and Human Services, Dr. Maddie Castiel. And our second panel will be moderated by HPC Commissioner and Vice President for 1199 SEIU United Healthcare Workers East, Tim Foley. Got that all out, yeah. Audience members, we do want this to be an interactive conversation. So at the end of each of the panels, we will have an opportunity for Q&A. So as you're listening to these reflections and these findings, please keep in mind if you have questions or comments that you'd like to contribute to the discussion. I've mentioned a few times the partnership with this new administration, and it is so important. And that partnership begins with Secretary Kate Walsh, who I know we in this room are all so pleased that she answered the call from Governor Healy to be the Secretary of Health and Human Services. We had hoped to have her here today to share some of her priorities for the administration. Unfortunately, some last minute travel plans have prevented her from being here, and I know that she is sorry that she couldn't join us. But in her stead, she has offered a really incredible person and friend to provide some remarks, acting under Secretary for Health, Karen Sung. I think everyone in this room probably knows Karen, who has shown such a deep commitment to healthcare policy throughout her career, through various roles at the Attorney General's office, HHS now, HPC, of course. And we are so grateful to have this new partnership with you. Karen, I hope you might kick us off with a few remarks. Thank you.
Thanks so much, David. Good morning. It's a real honor to be here to speak with you all on behalf of Secretary Walsh. I will do my best to fill her unfillable shoes and to provide some remarks on behalf of the Healy Driscoll administration. I really want to thank the legislature for your partnership on these critical issues and commend the HPC and the many healthcare stakeholders here today for underscoring the urgency of these challenges and for working together to ensure the creative solutions we need. The impacts of this crisis are being felt across the continuum of care in every corner of the Commonwealth, from hospitals to post-acute settings, to human service providers, to nursing facilities. No one is left untouched. As highlighted in this report, roles that were already experiencing pipeline challenges saw those exacerbated profoundly during the pandemic. What Secretary Walsh saw at BMC, what so many of you saw at your own providers, and what I certainly saw at my safety net healthcare system in Houston, were vacancy rates across a range of key frontline positions that approached or exceeded 30%. The Healy Driscoll administration knows this, and we are working hard to address the root causes of this crisis. We are coming at this from every angle: pipeline investments, retention efforts, regulatory flexibility, upskilling, and the use of innovative solutions to augment our gaps in staffing. Last week, to ease the end of the public health emergency, Governor Healy filed legislation to extend some key pandemic flexibilities, including lower minimum staffing requirements and eliminating some certification restrictions for certain healthcare providers. We know that regulatory flexibility is a critical piece of the puzzle, and we're working to ensure that there are no unnecessary administrative roadblocks to the provision of care in Massachusetts. Massachusetts has also been a national leader in shifting services from institutional to home and community-based settings. The acceleration of this sector's growth without parallel workforce investments would leave significant shortages in appropriately trained workers. The Commonwealth needs a workforce that is equipped to support its shifting needs. That's why just recently, we distributed more than $46 million in grant funding to support recruitment, retention, and training for home and community-based service workers. We're investing in those recruitment, retention, and upskilling efforts across the continuum of care in every role. In the supplemental budget, the Healy Driscoll administration has introduced a $10 million LPN Career Ladder program that would provide interest-free loans and grants to support tuition and living costs for students attending LPN certification programs. And in the next few weeks, we'll be announcing the recipients of $130 million in student loan repayment grants. Grants that come with a 4-year commitment because we know how important it is to retain people in these positions. Moving forward, another big piece of this will be the use of tech to augment our workforce. Our administration's fiscal year 24 budget proposal includes nearly $3 million for the Department of Developmental Services Technology Forward Initiative, which explores ways that we can use technology to modernize the provision of care. The world has changed. We have to challenge ourselves to think differently about these roles and our options, and we have to do so with equity in mind. As highlighted in this report, there is both an opportunity and an imperative to consider our efforts in the context of broader health equity aims. Strategies to support and stabilize the workforce can and must keep in mind communities that have historically been left behind, and the same communities that have been disproportionately burdened by COVID. Equity will continue to remain at the forefront of all of this administration's workforce priorities. Please know that the Haley Driscoll administration is committed to working with each and every one of you to continue putting in place the root cause solutions we need to address this workforce crisis. Thank you so much for your partnership, your expertise, your commitment. We look forward to tackling these challenges together. So let's get to work. Thank you.
Thank you, Madam Undersecretary. And yeah, let's get to work. Let's start our work by looking at some data and trying to understand. Let's start with a fact base. And so that's why I am so excited to announce and bring up our expert team from the Health Policy Commission, leaders in our research and cost trends team that really led the work on the HPC's workforce report. Dr. Sasha Elbert and Dr. David Auerbach. I'm going to turn it right over to Dr. Sasha Elbert, who was the lead researcher on this report to present our main findings and recommendations. After her presentation, we'll be able to have an opportunity for a little bit of a Q&A, so keep that in mind. But we're really excited to share this exciting work with all of you for discussion today. So with that, Sasha, I'll give you a clicker.
Thank you very much. Good morning, everyone. Glad to be sharing our work on the Massachusetts healthcare workforce and challenges in the era of COVID-19 with everyone here today. So as Chair DeVoe mentioned, the HPC was tasked with completing this report by the legislature in 2 recent pieces of legislation, which directed us to examine the impact of COVID-19 on the Commonwealth's healthcare workforce, including an exploration of workforce shortages, investments in healthcare workers, and workforce development initiatives. This report takes a high-level perspective on system-wide trends and challenges throughout the workforce lifecycle, from pipeline and training to employment, retention, and advancement, exploring elements such as degrees awarded in healthcare fields, employment and wage trends, turnover, and upskilling. In addition to system-wide trends, we also examined 3 workforces who provide care across sectors and settings of the health system, and who together make up about 2/3 of the Commonwealth's healthcare workforce. That's registered nurses, direct care providers, and behavioral health providers. And as Director Seltz mentioned, we recognize that there are significant workforce pressures in areas that this report does not cover in as much depth. And the HPC anticipates completing future work, more closely examining trends and challenges in other healthcare roles and professions, such as primary care, and in other healthcare settings, such as ambulatory settings and community health. So this pie chart depicts the healthcare workforce of the Commonwealth, including advanced practice nurses and physician assistants at the top, technician roles, physical and occupational therapists, physicians, and a wide variety of other roles. The slices of this chart that are highlighted in color indicate the roles that we'll be focusing on most closely today. These 3 workforces again make up about 2/3 of care providers in Massachusetts, with the orange and yellow segments showing direct care workers, including home health aides, psychiatric aides, personal care aides, and certified nursing assistants, with nursing roles that are in scope for this report in shades of blue. Additionally, about 40,000 of the care providers that are captured in this graph provide care in behavioral health settings. And there are also about 24,000 social workers, counselors, and therapists that are not included in this graph who are also providing behavioral health care in the Commonwealth. So we start our findings with a slide on some broad workforce trends, not affecting only the healthcare workforce, but the entire job market of Massachusetts. So as this slide shows, the ratio of workers to the total population of the Commonwealth has fallen by about 5% since the onset of the pandemic, meaning that labor markets are unusually tight. And notably, this doesn't reflect unemployment. The Massachusetts unemployment rate was at about 3% as of 2022, the end of 22 rather, which is a historic low. Rather, this reflects a reduction in labor force participation by older workers, i.e. more people have retired and left work entirely, which is a trend that we would expect to continue as the baby boom generation continues to leave the workforce. We've likely also seen some exits from the workforce or perhaps reduction in hours worked due to caregiving obligations, especially because of the need for more accessible childcare in Massachusetts. We also have an aging population, which is not only driving these drop-offs in our working population, but will also be a source of increased demand for care. So we don't expect this general labor scarcity to improve anytime soon. So now we're going to move more specifically into the world of healthcare. And here we find that employment trends have played out differently in different care settings. Here we look at year-to-year percent change in employment from 2020 to 2021 to 2022. And going from left to right on the slide, we look at offices of physicians, outpatient care centers, acute care hospitals, psychiatric hospitals, home health, and nursing and skilled nursing facilities. And here we find that employment has fallen the most and most consistently over time in lower resourced sectors, that is, the sectors that are the least able to compete on wages. And we know that in the current tight labor market, these lower resource settings, including not only nursing facilities, but also community health centers, have been losing care providers to settings with more resources, such as acute care hospitals. Just to cite a national statistic, over 2/3 of community health centers nationwide lost between 5 and 15% of their workforces during the pandemic. By contrast, we see relatively stable employment in acute care hospitals. But I want to note that this relative stability doesn't, this trend obscures all of the turnover that hospitals have experienced and all of the measures that hospitals have taken to maintain that stability, including reliance on contract labor, which we'll discuss more in a few minutes. And as part of this, we also know that this relative stability of hospital employment obscures the way that healthcare providers have moved among hospitals, because even within acute care settings, we have lower and higher resourced institutions, and some hospitals are more able to compete on wages than others. For example, as of mid-2022, academic medical centers had registered nurse vacancy rates of about 11%, which is compared to almost 20% at community high public payer hospitals. As another piece of background, we also have a particularly high rate of potentially avoidable hospital use in Massachusetts. Despite being among the healthiest states in the nation, we have the second highest Medicare readmissions rate, a high rate of patients admitted for inpatient stay from the emergency department, and as shown on the orange bar in the graph, the sixth highest rate of avoidable hospital use in the nation. We come in only after West Virginia, Kentucky, Mississippi, Louisiana, and Alabama. And this high rate of avoidable hospital use does no favors for our overstretched healthcare workforce. So moving forward from those high-level trends, this next section illustrates in more detail the current state of our healthcare workforce and some impacts on patients. This slide shows a simplified version of the various settings of care patients may need to access and move among. Ideally, patients in community at the very top of this flowchart would be able to access all kinds of outpatient care in a timely way, and would be able to access home health or long-term care when they need that level of support. And when patients do use the ED, if they can't be discharged to home afterwards, they would be able to get to the appropriate care setting in a timely way. Likewise, if patients are hospitalized and need post-acute care, they would be able to reach the right care setting when they're ready. However, when there are shortages of healthcare workers, patients may end up with delayed access to care, which we've indicated here in yellow, and with avoidable emergency department or hospital use, which we've indicated in blue. For instance, if patients lack timely access to needed outpatient care, they may end up seeking care in the emergency department when that's not really the best care setting for their healthcare needs. And we know that in Massachusetts, in addition to our high rate of avoidable hospitalizations, we also have a fairly high number of potentially avoidable emergency department visits. And both of those trends leave emergency departments and inpatient settings with more patients than they should really have. When there are shortages throughout the healthcare system, we find ourselves in a situation that looks like this. Patients who can't get timely behavioral health care may end up boarding in the emergency department. Workforce shortages in post-acute care mean that patients may stay in acute inpatient settings too long when they no longer need that level of care, but which requires staffing and other resources that are then unavailable for patients who do need to be hospitalized. And at the same time, staffing shortages in long-term care or home health can prevent patients from getting more intensive support when they need it. And while all of these are significant challenges, and it is hard to pick out just a few as the most significant, the situation seems especially dire with regard to transitions to home health and nursing facilities, because it means that patients are not getting the appropriate level of care, and it involves bottlenecks that can ripple throughout the whole system. I also want to call out ED boarding as a particularly significant challenge, and unfortunately not a new one. Additionally, staffing shortages among emergency medical services and medical transportation can further exacerbate all of these challenges. When patients may not only be unable to be admitted or discharged in a timely way, they may also not be able to move among care settings in the way that they need. And of course, this is not happening in every organization or to every patient, but at a high level, this is the situation we've experienced in Massachusetts in recent years. And we see the trends underlying these patient flow issues in our data. To start with, we see increases in ED boarding for behavioral health conditions, and especially for mental health conditions, from 2020 to 2022. ED boarding is when patients stay in the emergency department for 12 hours or longer. And at the beginning of 2020, 38% of patients in the emergency department for mental health conditions boarded in the ED. That's a share that had increased to half of patients in the emergency department for mental health conditions by last summer. That is, half of patients who were seen in the ED for mental health reasons were there for at least 12 hours. And to give a little bit more context to why this might have been happening, as of August 2022, inpatient mental health facilities had more than 560 beds offline due to staffing shortages. So there wasn't always somewhere for these patients to go. So now we'll move to trends underlying challenges discharging patients from acute to post-acute care. This slide shows quarterly change in employment relative to the beginning of 2018, comparing ambulatory care, hospitals, and nursing and residential care settings. And we see employment fall to varying degrees in the spring of 2020 with the onset of the pandemic in all three of these settings. But employment in nursing and other residential care settings still hasn't recovered. As of last summer, it remained about 14% below 2018 levels. Staffing shortages in post-acute settings can lead patients to spending longer in the hospital than they otherwise would. Here we see average length of stay by discharge setting over time, with increases for patients discharged to home health in the yellow line in the middle, and to skilled nursing facilities shown at the top. And most notably, patients needing to be discharged to skilled nursing spent an average of 7 days in the hospital at the beginning of 2019, but almost 8.5 days as of last year. Throughout 2022, hundreds of patients remained in hospitals awaiting discharge to post-acute care, with the largest number of patients consistently awaiting discharge to skilled nursing. And again, these are patients who no longer need to be hospitalized, but they can't be discharged to home, so they're waiting for the appropriate care setting to become available to them. And for this large number of patients who need skilled nursing care, combined with those patients' longer average length of stay, as we saw on the previous slide, this all leaves fewer resources for patients who do need to be hospitalized. So these are all consequences for patients of current staffing shortages throughout settings of care. And for healthcare delivery organizations, many have had to rely heavily on contract labor in an effort to maintain staffing and fill key staffing gaps. And there are a few ways that these healthcare roles can be structured, but we use contract as an umbrella term to refer to all of them. This slide shows the share of hospitals' patient care labor costs that is made up of spending on contract labor from 2011 to 2021. And we found that much like in other states, hospitals in Massachusetts, which are shown in the orange, have increasingly used contract labor to maintain staffing, particularly during the pandemic, with contract labor representing about 5% of hospital patient care labor costs as of 2021. And I do want to note that that's an average, and at the level of the individual hospital, contract workers made up from about 3 to 9% of patient care labor costs across most of our hospitals. I also want to note that the data underlying this analysis so far, unfortunately, was only available through 2021, and we know that a lot has changed since then. But recent estimates from survey data suggest a notable increase in spending on contract labor into 2022. We also find that wages for contract workers at hospitals rose sharply during the pandemic. This slide shows change in average wages for patient care staff, comparing contracted hospital staff in the blue to employed hospital staff in the orange, again from 2011 to 2021. And we see much faster growth in contractor wages starting in 2020. Other research finds that for nurses in particular, as of 2022, average wages for contract nurses in Massachusetts were about 189% of average wages for employed nurses. Long-term care facilities have also had to rely on contract labor. This slide shows contract hours as a share of total hours worked in long-term care facilities for registered nurses, licensed practical nurses, and certified nursing assistants. And to highlight the most dramatic trend, as shown in the blue line, the share of nursing hours worked by contracted registered nurses in long-term care facilities has quintupled from 4% in 2019 to 19% in 2022. So from all of these high-level trends, we'll now move on to the next piece of our presentation, which includes sharing our findings specific to the three workforces we highlighted at the start of the presentation, starting with registered nurses. So to set the stage, we show demographics of our registered nurse workforce as of 2021. And by race and ethnicity, as shown in the pie chart, the distribution of RNs in Massachusetts is actually not too different than the overall population of the state. Likewise, we see a similar share of immigrants or foreign-born nurses who represent 15% of the RN workforce, compared to about 17% of the total population. However, I do want to note that 90% of registered nurses are women. We have very little gender diversity in our nursing workforce. This slide shows RNs per capita in Massachusetts and the US as a whole, with shades of blue indicating nurses working in hospitals and in non-hospital settings, looking at trends from 2015 to 2021. Based on these trends, we don't appear, even in recent years, to have seen a significant decrease in our RN workforce. In fact, we consistently have more nurses per capita in Massachusetts than the US as a whole. And as of 2021, Massachusetts had about 1,300 RNs per 100,000 residents, compared to about 1,000 in the rest of the country. And on a per capita basis, the Massachusetts supply of RNs has grown by 12% since 2015. And these are statewide numbers, so this doesn't address how our nursing workforce is distributed throughout the Commonwealth. But on a Massachusetts-wide basis, we don't appear to have lost nurses into 2020. We also find that the pandemic did not appear to affect the number of people completing nursing programs. This slide shows the total number of graduates from different types of nursing programs over time, from shorter certificates on the left through advanced degrees on the right, looking at trends into 2020. And the total number of graduates remained steady into 2020, and we actually saw an increase in the completion of advanced degrees. Likewise, to look a little bit more recently, the total number of people passing the NCLEX RN licensing exam increased by 3% from 2019 to 2020 and fell by only 1% in 2021. So while we know that it's important to maintain a strong nursing pipeline, we also know that the pipeline is leaky, so to speak, as far as a means to increase our overall supply of nurses in the state. For every 100 nurses educated in Massachusetts, only about 65 are still working here after 5 years. And that's a share that decreases over time, such that after 25 years, only 58 of those 100 nurses are still working here. To put this another way, 42% of the nurses educated in Massachusetts will eventually move on to practice in other states. And this is not unique to Massachusetts. We found that other states had a similar attrition rate. People go to nursing school and they move around. And on the flip side, about a third of the nurses working in Massachusetts were educated elsewhere. But we know that there have been significant challenges in nursing in the last few years. So if the nursing pipeline doesn't appear to be the biggest challenge, what would we say that it is? We find that challenges for the nursing workforce have more to do with employment and retention than with pipeline and training. So this exhibit shows 2021 to 2022 results from a survey of Massachusetts registered nurses. And as you can see, the most common issue they report is not having enough time for their patients, of being stretched too thin. And while that was a challenge that nurses also reported prior to COVID, the share of nurses saying that they didn't have enough time for their patients increased by about 20% compared to 2017. And nurses are also reporting troubling rates of workplace violence. A larger share of nurses reported facing just about all of these challenges compared to pre-pandemic trends. But how might that have happened? Some of the biggest challenges reported by nurses relate to high turnover and reliance on contract labor. And while we want to be clear that contract labor has been essential to fill staffing gaps during the crises that we've seen, heavy reliance on contract labor can strain incumbent employed nurses who may need to orient them or take on additional administrative responsibilities that contract workers don't carry out. And this strain may lead additional experienced nurses to leave, exacerbating turnover and loss of institutional knowledge, and raising costs for organizations who need to hire or contract more nurses to replace them. So we depict that dynamic for hospital nurses in particular on this slide. On the left, we have a unit of nurses caring for their patients. And then moving into the second column on the graph, with the onset of COVID, increasingly stressful work conditions lead some experienced nurses to leave hospital care for other healthcare roles or to retire earlier than they would have otherwise. And we saw this happen in Massachusetts hospitals. Registered nurse vacancy rates in our acute care hospitals doubled over the course of the pandemic, from about 6.5% in 2019 to about 13.5% in 2022. And again, with especially high rates in community hospitals. Moving to the third column on the slide, difficulty attracting experienced nurses as permanent hires may lead the hospital to backfill with contract nurses, which we show in the lighter blue, and who, as mentioned, need to be oriented by employed nurses and are not taking on regular administrative duties. The hospital may also backfill with recent nursing graduates, which we show in the orange, and who need more support and mentorship in order to succeed than highly strained nursing units may be equipped to provide. So under these conditions, at the very end of the slide, further experienced nurses may leave. New nursing grads who have not been able to be set up for success will also have high turnover, and the whole nursing unit faces a cycle of entrances and exits, a loss of institutional knowledge, a depletion of continuity of care, and further strain for the nurses who remain, some of whom may then leave themselves. So for one last data point on our nursing workforce, we took a look at the distribution of our nursing workforce by age. And we found that that Massachusetts nurses on average are older than in the rest of the United States. So this slide looks at nurses who are under age 35, ages 35 to 49, and ages 50 and older, comparing the share of nurses in those age ranges in Massachusetts in the orange bars and in the US in the blue, 2019 versus 2021. And if you look at the segment of the graph on the right-hand side, Massachusetts not only has a larger share of nurses over age 50 than the rest of the US, our share of nurses age 50 and older has risen over time and over the course of the pandemic. While in the middle section, our share of nurses ages 35 to 49 has fallen. And we would anticipate some of the nurses in that older age group leaving the workforce over the coming years, which further highlights the need to focus on retention for the nurses we have providing care now. So to summarize, while there are ways that our nursing pipeline could certainly be strengthened, we find that nursing shortages reflect turnover, attrition, and challenges in that stage of the life cycle rather than an overall lack of nurses. So our next section is on the direct care workforce, encompassing nursing assistants and aides. And here we see that half of Massachusetts direct care workers are immigrants, and this workforce is largely composed of women of color. For this workforce, we find challenges at all stages of the workforce life cycle. To start with, we appear to be training fewer direct care workers. Massachusetts has more direct care workers per capita than the US as a whole, but employment in these roles is falling. Excuse me. Yes, but employment in these roles, oh, wow, I have lost my spot, excuse me. Here we go. To start with, let's try this again. To start with, we appear to be training fewer direct care workers. This slide shows all levels of certificates, awards, and degrees for health professions and clinical sciences in Massachusetts. And while we see more or less steady completion of bachelor's and advanced degrees, completion of shorter degree programs, which are the types of programs that are training direct care workers, has fallen over time. Right, this is the slide on employment. We also see declining employment of direct care workers. Massachusetts, as you can see on the left, or excuse me, on the right-hand side, has more direct care workers per capita than the US as a whole, but also much more quickly declining employment. We've seen a 15% decline in employment of direct care workers from 2019 to 2021, compared to a 9% decline in the rest of the country. So our findings indicate that the main challenge for our direct care workforce is wages and the high cost of living here in the Commonwealth. This slide looks at wages in recent years for certified nursing assistants in the light blue and home health and personal care aides in orange, and compares them to wages outside of healthcare, specifically in food service, which is labeled wait staff here in the dotted dark blue, and in retail, which we've labeled as cashiers in the gray. And we also compare all of these roles to the state minimum wage. And we look at these trends to show that wages for direct care occupations are not much higher and are not always growing as quickly as wages in these other sectors of our economy. And I also want to note that the cashier number here is an average. The largest employers are able to offer much higher wages, up in over $20 an hour. And direct care workers may leave healthcare for less stressful work for similar or even higher wages outside of healthcare. I also want to note that MIT has estimated that a single adult with no children in Massachusetts would need to earn almost $22 an hour, which is more than all of these occupations. And a national estimate from prior to the pandemic was that 44% of direct care workers were living under 200% of the federal poverty level, and that 42% qualified for public assistance. So this isn't a new challenge, but tight labor markets as a result of the pandemic and large employers, particularly retailers outside of healthcare, who have been able to really significantly compete on wages, have meant that more workers have left the field. So to illustrate this cost of living idea further, we compare average annual compensation for CNAs and aides to the cost of living in the Boston and Worcester metro areas, looking at housing, transportation, and other costs. And we do this to show the very real wage pressures that people in these roles face. And when these pressures are combined with a lack of clear avenues for advancement, this could lead to direct care workers potentially opting for acute care careers, staying in healthcare, but moving to settings that are able to compete on wages, or leaving healthcare entirely, as we discussed on the previous slide. So for the direct care workforce, we find that low wages and our high cost of living state are the crux of challenges at all stages of the workforce life cycle. The prospect of relatively low wages may limit the pipeline, and the upfront cost of training may be burdensome for those covering the cost out of pocket. And while not all trainees will need to pay for their own training, just to give an example of what it might look like for those who do, CNA training out of pocket costs about $2,000, and when the goal at the end of training is to make $18 an hour, that's a fair amount of money to have upfront. We also find that low wages for direct care roles may contribute to high turnover, especially in lower resourced settings. And when there's a lack of clear opportunities for advancement that don't place a financial burden on workers, that is when workers need to pay for their own training or miss work in order to complete it, that makes it hard to stay in the field. Our last workforce of focus today is behavioral health, including roles such as social workers, counselors, therapists, psychiatrists, as well as nurses, aides, and other healthcare providers who care for patients in behavioral health settings. And I want to note that this is such a heterogeneous workforce, at least professionally speaking, that we weren't able to offer the same kind of demographic breakdown as for the other two workforces we focused on. So looking at behavioral health training, we find that the overall number of completed mental and behavioral health degrees and certificates in the Commonwealth has declined, mostly, as you can see by looking at the right-hand side, due to declining completion of advanced degrees. Similarly, we find falling employment in some of the roles that require these advanced degrees. For example, employment of mental health and substance use social workers in Massachusetts fell by almost 16% from 2019 to 2021. The behavioral health care continuum includes community and office-based settings, as well as intensive outpatient, acute inpatient, and residential care. And this slide looks at year-to-year percent change in employment across these settings of care. We see rapid employment growth in the settings that are adaptable to telehealth, the two office-based settings on the on the left, and slower growth or falling employment in intensive outpatient, inpatient, and residential settings, where care would need to be provided in person. This slide looks at year-to-year percent change in wages in those same settings of care, and these trends look pretty different. We see rapidly rising wages in intensive outpatient and inpatient psychiatric care, which suggests a shortage of workers in those settings. So for behavioral health, we find that challenges relate to the high cost of training and the division between in-person and telehealth care. That education and training for many roles could be expensive and time-consuming, especially roles requiring advanced degrees and licensure, and compensation for many roles can be low, which could be especially challenging for pre-licensure providers who may not be able to bill insurance, or providers who completed advanced degrees and now have student debt. We also see high turnover with varying trends by setting, finding that employment has rebounded when care can be provided by telehealth, but is still challenging for in-person care settings. We also want to note that there are relatively few middle rung roles in behavioral health. Many roles are either entry-level or peer roles, and then there are roles that require advanced degrees, which could make advancement in the field particularly challenging. So what could be done about all of this? Our next section highlights our exploration of 5 examples of workforce initiatives aiming to address challenges throughout the workforce lifecycle. And we share these to highlight that although the challenges we've documented and that we're all acutely aware of are complicated, we're not necessarily starting from scratch as far as ways to address them. So this slide shows the 5 initiatives we looked at, and going from left to right, starting with pipeline and training, Mass Senior Care has put together a program recruiting resident care assistants to train and certify as CNAs to help alleviate long-term care staffing shortages. The 1199 SEIU Training and Upgrading Fund ran an apprenticeship program for sterile processing technicians at Steward hospitals. And this is a role that's responsible for sterilizing and organizing equipment used in operating rooms. Moving to retention, MGB Home Care created a home phlebotomy team program to alleviate blood draws from home care nurses' schedules and allow them to focus on care that really requires nursing expertise and to support home care nurse retention. South Shore Hospital has a set of transition to practice programs, training hospital medical surgical floor nurses for specialty care. And lastly, Baystate Health has programs to train current Baystate employees and advance them into clinical support roles, seeking to alleviate shortages in roles such as pharmacy technicians. So for this piece of our study, we interviewed several people involved with each of the workforce initiatives. This slide shares just one example of a respondent perspective from each one. And it's much too much to read through, but just to pick a couple to share aloud with you all today. Starting with the third bullet down, a case management nurse from MGB Home Care said that the phlebotomy team program allowed nurses to focus on care requiring nursing expertise, saying that they realized how much time it freed up for us because drawing a lab is sometimes a simple thing, but it's extremely time consuming. Likewise, looking to the bottom of the slide, a graduate of the pharmacy tech program at Baystate said that the program they had just gone through would benefit workers seeking but struggling to find new opportunities, saying there's plenty of people who want to do better and get better jobs, but for whatever reason, they just can't. Programs like this will be perfect for them. And we have much more in-depth information about each of these programs in our full report, which I'd invite you to read if you'd like to learn more. And also folks from the organizations involved in the other 3 initiatives will be on our first panel following this presentation. So as different as these workforce initiatives are, there were several themes that we heard in common across all 5 of them. The importance of planning and collaborating, the value of hands-on learning. Respondents also found that training programs can strain existing staff who are serving as mentors, but are also stretched thin by the very shortages that the training programs seek to address, and that mentors may need some additional support. We also heard that successful advancement initiatives need to plan for the new challenge of backfilling the roles that are vacated when workers upskill and advance into their new jobs. Another common theme was that initiatives are often expensive for organizations to run, and funding from the Commonwealth could help to support their sustainability or help expand them to less well-resourced institutions. And lastly, organizations agreed that more education for organizations about Commonwealth healthcare apprenticeships would be beneficial because many organizations don't know that they're available. So to wrap up, we found that tight labor markets today and likely in the future will require adjustments to make healthcare careers more attractive and sustainable. The trends that we've measured and that we've just shared with you today largely reflect pre-existing challenges that were exacerbated by the pandemic and the tighter labor markets that the pandemic created. And we want to be clear that the trends that we found reflect the aggregate consequence of individual healthcare providers making rational choices for themselves and their careers under challenging circumstances, seeking better pay, better working conditions, more schedule flexibility, and that under the pressures of the pandemic, the circumstances of their employment were no longer working for them. And so the focus needs to be on how those circumstances could be improved. Also, targeted investments from the Commonwealth could help to seed workforce initiatives or enhance wages for under-resourced sectors and roles. And healthcare delivery organizations could invest in their workforces with opportunities for advancement or with care delivery innovations to support job quality and retention, such as those collected in a compendium from Mass Health and Hospital Association earlier this year. So moving to more specific recommendations for nurses, we highlight recommendations for healthcare delivery organizations in this left-hand box, recommending that healthcare delivery organizations focus on job quality and retention with mentoring and coaching, effective use of administrative and support roles, and schedule flexibility. For the Commonwealth, we recommend that the Commonwealth support nursing schools in streamlining their clinical education requirements to help reinforce the pipeline. And we want to note that making investments in nursing retention will actually serve to further reinforce the pipeline because experience and stability on nursing units are needed to provide effective clinical education for students. Additionally, one area where the pipeline could be reinforced is ensuring that clinical education for nurses takes place in a wider range of settings, not only in hospitals, but also community health or home health settings. For direct care, healthcare delivery organizations could focus on supporting workers as they transition into employment to help set them up for success, and by offering opportunities for professional development and advancement to help retain them. And the Commonwealth can reduce barriers to entry and support retention by expanding upfront financial support for training, so workers don't need to pay for training or miss wages in order to advance in the field, and with policy change to enhance wages. For behavioral health, healthcare delivery organizations can focus on reducing turnover, again through higher wages or opportunities for development and advancement, while the Commonwealth could provide upfront financial support for education and training. So we have additional detailed recommendations in our full report, which is available hot off the presses this morning on the HPC website. And we look forward to building on this work with exploration and trends and challenges in other roles and professions and in other sectors and settings of our health system. Thank you all again. Really looking forward to the discussion and to hearing additional thoughts and ideas from our panelists.
Wow. Thank you so much, Dr. Albert. That was, I'm overwhelmed. There's so much good material there and so much to really think on. So thank you so much for this incredible work and for the work in putting this report together. And for all of the stakeholders that we consulted along the way, thank you for your input in this work. We do have a few minutes before we have to turn to our first panel to see if there is any questions from the audience for the lead authors of this HPC report. Oh, Commissioner Cohen.
Sasha, David, thank you. Wonderful research, great data. I think the points you made relative to each of the professions you looked at are so important and right on the money. I want to talk a little bit about the behavioral health recommendations. And you note that there's a need that supply has decreased recently, and there's a need to focus on supply. My concern is we've had a supply problem in the behavioral health field prior to COVID. Yet, of all the states in the country, we have the highest per capita number of mental health professionals and have had that for easily 10 to 15 years. So, and pre-COVID, we had boarding, we had long waits for outpatient appointments. So beyond supply, what else should we be looking at behavioral health if we're really trying to ensure that there's adequacy in care being provided?
Yeah, absolutely. I think that's a really good and important question. I mean, one of the elements that, as I noted, we were unfortunately not able to focus on and that we think is going to be essential is workforce diversity in behavioral health. I mean, we know that diversity in all healthcare roles and especially in behavioral health is critical to achieving greater equity. And we want to be able to not only measure it, but understand, what organizations are doing to help support a more diverse behavioral health workforce and what the Commonwealth can do to help reinforce those efforts. We're also looking forward to understanding a few newer initiatives that the Commonwealth has launched that are aimed at increasing access to behavioral health services. Again, so not speaking specifically to supply, but sort of new avenues for access. Notably the Behavioral Health Helpline and Community Behavioral Health Centers. And we actually have a few reports that are legislatively mandated to examine access to services, including via those avenues, which we look forward to working on in partnership with Health and Human Services and CHIA colleagues.
Thanks, Sasha. And if you have a question, please come right to the microphone. I see Commissioner Cutler, if you would.
Don't want to jump in front of the commissioner.
Go out.
My bad timing. So So I'm Tim Quigley from South Shore Health. Fantastic data, great presentation. So thank you for that. One of the things I worry about is when you look at the nursing shortage, or from a global perspective, and look at other models of delivery, the UK has 40% of their care being delivered by agency nurses, and the rate between the NHS rates and the agency rates are so significantly different that almost half of their care is delivered by agency right now. Have you looked at how they got because you've got a government payment, 60 cents on every dollar coming in drives a lot of you looked at the difference in your own data between the community and the academics. And then there's a significant concern that I think people are going to look at the economic return on a long-term travel. I talk to young folks in nursing. I'm a nurse myself, been chief nurse for 25 years, 35 years, I guess, a long time. So but the reality is that many folks now identify themselves as travel nurses at the younger part of career. So I worry that people are thinking that's, the Inc. versus being mission driven, part of an organization doing a larger piece. So have you thought about that and any kind of concepts? And appreciate your answer. Thanks.
Yeah, I'll start off just to say, I think that's a great question for some of our panelists too. Do we see these trends persisting? Do we see them changing once some of these new opportunities have made themselves available? Is there an unringing of that bell, or is there a need to kind of adapt to a new normal? I think that's a really important question. I don't have the answer. I would note, and I think it's a good question for our research team, is to think about where, in many cases, when we look at, kind of per capita professions, and the numbers, oftentimes Massachusetts ranks pretty well in terms of per capita healthcare professionals. But it's not clear to me that that's still the right numbers. And so are there opportunities maybe to look at to other countries to think about how they balance their workforce in different ways, and what is kind of a well-resourced workforce? So I don't know if you have anything to add on that, research team.
I think you're partially speaking to the first question as well, that in so much of our healthcare workforce, we have relatively high numbers if you look at other states, but yet we have these shortages. We have people not accessing care. And you have to think about, are they working in the settings that we want them to be? Are people serving the full population, or just, those folks at the higher income end? Are people accepting mass health? Are they taking insurance? All these issues can lead to this apparent paradox. And on the travelers, thank you for that data on the UK. I was not aware that it's different there. I'd love to learn more about the situation there, but we wish we had better data on the traveling phenomenon, and we have what we have, and we always would like more data.
Great. Thank you, Commissioner Cutler.
Thank you. So this was just terrific. So thank you so much. I have about 1 million questions, but I'll stick with just one. I want to understand a little bit more the situation of the hospital nurses, because it's something we hear about a lot. And so there are a couple things in the report, and I just want to learn how to reconcile them in my mind. One thing is that the total number is actually up slightly. So that was on chart 7 of it. And then the second fact is that we're using more contract nurses. And so I'm trying to reconcile how the number is up slightly and we're using more contract nurses. And I think you gave 2 stories, and I just want to try and understand them. One story is that overall demand is so much higher that the increase in supply is not enough to meet demand. And so therefore we have to hire contract nurses. So that's a story about sort of demand for hospital care. And the second one is that, in essence, the nursing workforce has become less productive because of turnover and need to train people, and trying to fit people in outside of usual work arrangements. And so that's meant that even with more staff, you can't do all the things you need to, and you need more staff. And so I'm trying to figure out which of those 2 or both are responsible for the situation that we're seeing.
Yeah. So, I mean, I think the nursing story that the data has provided to us is really a story of turnover, and also of nurses sort of moving to settings of care or healthcare roles, even that are not direct patient care, in higher numbers than they were prior to all of the disruptions of the pandemic. If we have as we showed, a fairly high share of nurses in Massachusetts, but many of them are leaving the hospital setting to work in, in outpatient care or other settings, or are leaving patient care for healthcare roles such as research or administrative roles. We would have a sort of a large per capita number of nurses, but that doesn't necessarily speak to where they're working.
I'll just add that hospital bar, yes, you do see the hospital employed RNs increasing, but that does include hospital outpatient settings as well. So you can have that shift, and it still makes the acute hospital situation.
So you think
tough.
there's partly a substitution from the inpatient and to the
There probably is
outpatient,
some of that.
and-
Mhm,
And that's then the shortage on the inpatient.
mhm.
Okay.
Thank you, Carol Allen, former commissioner. So thank you for this work. It's really impressive. And I think you're hitting on a lot of potential solutions that could really help. What I didn't hear was interrelationships between the different sectors. And I also didn't see anything about physicians and physician workforce, which I think will become an issue and in many ways mirrors what you're seeing with the RNs. A lot of early retirements, a lot of burnout and frustration. So I hope that you would look at how these different levels of workforce interact with each other and depend upon each other, because, as you squeeze one end of the balloon and something else gives. I think that's part of what's going on. And even also different subspecialties. So for example, you may talk about mental health, but to me as a pediatrician, I care about child psychiatrists and child health workers, mental health workers, and there may not be any, I know there aren't enough. So I hope that you look at the different sectors and how they interact and support one another, and how you can, if you support, for example, for physicians who can't find people to work in their offices, that impacts on their patients because they can't get appointments because there's no one to support the physician seeing the patients, or if the patient's spending, if the doc's spending 60% of their time on paperwork, that could be easy. And this applies to nurses as well. Somebody else could be doing that work. So look at it, get down into the weeds. But thank you for this work.
Yeah, thank you.
Thank you, Dr. Allen. And we completely agree. And I think, as I said earlier, we really see this report as the first of many deep dives and examinations into the different workforce trends in Massachusetts. The primary care one is one that is top of mind to me as well. I think we've all seen some news articles around the extended wait times to even get a primary care preventative visit. So that is absolutely really important. And I think the other point you made is I think we try to hit this in the report, is the fact that this is all interconnected and that pressures in one area can bleed into pressures in another area. And that we do need to kind of think of this as an interconnected problem that needs interconnected solutions. And if we just have a solution for one part of this workforce, we're likely just going to, as you said, push the balloon in another direction. And that, I think, is really our hope for these panels that we put here together. We really try to think about these panels as representing a cross continuum to help to think about where we can go next.
Can I just ask?
Yeah, of course.
One comment on that. A great example of that interconnectedness you mentioned that we do note in the report is there have been more RNs getting advanced degrees and becoming nurse practitioners and other APRNs. And that does directly, add to one workforce and subtract from another. And it's an important trend, partly because there are fewer primary care physicians. We need that, but it is all connected, as you say.
Morning, Juan Fernando Lopera. I'm the Chief Diversity, Equity, and Inclusion Officer at Beth Israeli Health. I'm also a new member of the Advisory Council for the HPC and co-founder of the Health Equity Compact, and pleased to hear equity being top of mind, and member of our Health Equity Compact is here, Elaine from SEIU, and I know Michael Curry will be speaking later. I wanted to, so I appreciated all the recommendations. Where I continue to be stuck is the 3%. 3% unemployment rate. We're at full employment in Massachusetts and across the country. So it's a supply and demand issue. Where are we going to find, so we can have all the great recommendations, but where are we going to find people? We've relied, population growth in Massachusetts and really across the country has relied on immigrant talent coming in. And there's been a significant shortfall in that talent due to previous administration, Washington administration policies, and certainly COVID travel restrictions all impacted immigration. So we have a significant shortfall, which in Massachusetts is north of 30,000 in terms of immigration shortfall. There's within our four walls of our state, we have 209,000 undocumented immigrants. If you look at places like Chelsea, epicenter of COVID, where a lot of folks were impacted by COVID because they were afraid of their immigration status. We have census telling us that there's about 40,000 people, when we really know there's about 60 or 70,000 people if you account for every single person. So how do we solve for that is a question that I think as a Commonwealth we need to solve for. And I know it's very complicated. We try to address the federal issue, there is a dead end. But we've been able to figure out driver's licenses. Can we figure out work permits for the 209,000? I was looking up data on the Migration Policy Institute website for Massachusetts 2019 data. About 33% of those 209,000 people are well educated. They have a college degree, they have some college, they have a professional degree. So how do we find them, and how do we get them employed, and how do we provide work permits? I was on WhatsApp with a dear friend who's the CEO of Guardian Healthcare Home Health Agency that focuses on Jose de la Rosa, who focuses on culturally competent, linguistically appropriate care in many of our communities here in Boston. And he's in the Dominican Republic, where he's from, trying to get 30 visas to bring people to become home health aides at Guardian Healthcare. He could just go to Lawrence if we allowed for work permits. And he said, please let the commission know that I'm here trying to figure this out. And if we could figure out solutions that are in Massachusetts, then home healthcare agencies and systems like Beth Israeli Health and others could benefit from the 200,000 plus undocumented immigrants who are here and willing and able that we can provide. Thank you.
Thank you.
Thank you, Juan, for that comment. And as we noted in the report, with the tight labor markets, we think that that's something that's going to continue. And so when you talk about that 3% and the pressure on that, we do need to be thinking creative in terms of how we can grow and train our workforce. And as Sasha highlighted in her work on the direct care workforce in particular, heavily immigrant workforce, how can we expand those opportunities to get into that workforce and also to advance in that workforce? Julie, I'll let you have the last question.
I'll be quick. Julie Pinkham, Executive Director for the Mass Nurses Association. Just a quick question on the issue of contract nurses, because it's going to take, I think, a center stage in some of this discussion. I know that you have difficulty with data, but whether or not you are currently looking at the number of nurses that actually are contract nurses that change their category. As you know, the regulation was changed during COVID. So we did not have 3 categories. We had 2. There was the agency nurse and the travel nurse. The travel nurse had to be 200 miles away. We created a new category called fixed contract nurse, which pretty much mitigated the other 2. I'm wondering how many of those numbers are actually core staff that migrated into contract positions, and if we can look at why that was.
Thank you, Julie. That is a question that I would very much like to answer as well. I think it's an important to understand the shifts in the employment status for these nurses, and were these, how many of them moved into this fixed contract nurse situation. I would say a few things on that. One, we're really grateful for a partnership with the Center for Health Information and Analysis, who is developing and prioritizing work on doing more survey work of our healthcare workforce. We think this is going to be a tremendous benefit to create more of a foundation of evidence so we can track in more real time how these dynamics and trends are changing. And as also part of that work, we're also looking to refresh some of the financial reporting from our acute care hospitals so that we can really try to kind of understand and splice between kind of different types of salaried employees and see how those trends are changing over time. So appreciate your support in making sure that we can get that data to really understand that.
I'll just note that as Andrea knows, we're also working with Bourne to try to add those questions to the nurse relicensure survey, which would be fantastic if we could learn more that way too.
Yeah, agree. This is a crucial piece of the picture that we should really be able to understand.
Well, thank you all. Thank you, doctors, for your presentation. I think we're excited to move on to our first reactor and stakeholder panel. Yeah, right.
All right. Well, good morning, everyone. As we break this table quickly, my name is Colleen Elstermeyer. I'm the Deputy Executive Director of the Health Policy Commission. I'm good. Thank you. Pleased to see you all here today for this very important topic, this very important discussion. I did want to acknowledge that we have almost 200 folks watching on the live stream today. So shout out to you all and thank you. Many of our staff, HPC staff, are also watching on the live stream. So thank you to all of them as well and for putting on this incredible event. We really appreciate it. So turning now to our first of two panel discussions. The first panel is titled Reactions from the Front Line, Unique Challenges and Solutions Across Healthcare Workforce Sectors. This is a 90-minute panel. We are going to break early at the end for Q&A opportunities, so get your questions ready. It is my absolute honor to introduce our first panel moderator, Dr. Maddie Castiel. Dr. Castiel is a primary care physician who does absolutely incredible work with the underserved in the Worcester community. She was appointed to the HPC's board at the end of last year, and we could not be more thrilled to have her working with us and have her perspective added to this discussion. Dr. Castiel excuse me, immigrated to the US from Cuba, was raised and educated in California, but did her medical residency in Massachusetts at UMass Memorial. She wears many, many hats, but I did just want to mention that in addition to practicing internal medicine, she founded and continues to serve as the medical director for the Latin American Health Alliance, which is a nonprofit organization I know many of you have heard of in Worcester and dedicated to combating homelessness and drug addiction, excuse me. In 2015, Dr. Castiel was appointed to be commissioner for the City of Worcester's Health and Human Services Department, currently serves in that role as well. And as I said, we are honored to have her serve on our board. So would ask Dr. Castiel, as well as her panelists, to join me here on the dais and be seated, and we'll get started.
So welcome all of you. I am thrilled to be here and thrilled to be here with this amazing panel that we are going to solve the solutions to the workforce, right?
That's right.
That's right. Okay.
David said so.
All right. So I'm going to start with Sharon here, and I'm going to go down the line. If you could just do a quick introduction of yourselves.
Sure. Good morning, everybody. Thank you for having me. My name is Sharon Stem, and I am the Associate Chief Nursing Officer at South Shore Health for Professional Development. South Shore Health, for those of you who are not aware, is an independent community hospital in Weymouth, Massachusetts, which is about 12 miles south of Boston. We have 6,000 employees, and about 1,600 of them are registered nurses in various roles. I've been a nurse for 26 years in various roles, including med-surg nursing, emergency department nursing, and in leadership roles that all empower nurses. Currently, acute care challenges are of the highest and the most extreme. We're taking care of patients who are more complex, and discharge challenges continue to increase, all while turnover could be at an all-time high on some units at 30%. We are dependent upon novice nurses to care for patients. COVID brought out many of these issues to the forefront, but the data really suggests we probably should have been a bit more prepared. My current role I am in as the ACNO of professional development. I have the privilege of supporting novice nurses moving into the profession of nursing, as well as experienced nurses to become lifelong learners and encouraging them to do so. I help them identify the professional growth that they're looking for and really help them answer the question of what's next for them. For some, it may be moving into a specialty area, and for others, it may be trying to retain them and their expert knowledge to impact, maybe change their current role, but to impact the newer nurses. The team that I lead is called the Clinical Professional Development Specialists, and their role is to promote professional development among nurses and also really to help recruit and retain them through doing this. We've created a system at South Shore Health that engages and supports all levels of nurses in all of their abilities. But the lift is great to help people move through the transition of nursing and into different areas. It takes time, it takes resources, and it's a process, so it takes follow-up. I'd like to add that one of the most important things in my role is our robust partnerships with workforce development agencies, as well as colleges, to take any spark from any person who's interested in entering healthcare and really help feed that, grow that, and engage with them to find the right path and the right area of entry for them. At South Shore Health, we believe that the voices of nursing need to be at every decision from bedside to boardroom and really beyond. That will help make the right decisions, especially during these unique times. Thanks.
Good morning, everyone. Is this on? Oh, yeah. I'm Jake Krilovich. I'm the Executive Director of the Home Care Alliance in Massachusetts. We represent about 190 home health, home care, and hospice providers throughout the state. And they span the spectrum of personal, non-medical, private pay home care to home health, certified home health with nurses, therapists. And then there's also a subset of our membership that provides services to medically complex pediatric patients in the home through the state's continuous skilled nursing program. Thank you.
Thanks, Jake. Good morning. My name is Tara Gregorio, and I am president of the Mass Senior Care Association, and our membership includes long-term care facilities as well as ancillary providers from across the Commonwealth. I'd like to begin, as I always do, by thanking the 52,000 individuals who work in our nursing facilities. These are mission-driven individuals, 90% of whom you heard are dedicated, compassionate women. 63% are people of color, and most not yet earning a living wage. I'd also like to thank Health Policy Commission and certainly Sasha for just an extraordinary report. I mean, I couldn't have said it better in regards to describing the challenges. And David said it best when we cannot underscore the urgency of action, not just because it's massively disruptive in that wonderful chart relative to the healthcare system, but there are 33,000 individuals living in nursing facilities today that it is imperative we provide them with a workforce. I also, because I'm in a room with so many people who have just been so supportive of me personally, as well as the workers and residents and their families over the past 3 years, that I just want to say thank you. It's just been phenomenal, the support and the people that leaned in to really help during an extraordinary time. So thank you.
Thank you. Thank you. Good morning, everyone. My name is Felaine Duranette. I am Vice President at Large at 1199 SEIU. Our members, they span a number of jobs, positions in hospitals, health centers, across long-term care, our mass PCA program with thousands of home care workers there. In addition to lending my voice in strategic planning and working with our members at 1199, I also serve as Executive Vice President at the AFL-CIO, the largest labor coalition of unions. I serve as board member at the Mass State Health Connector, obviously providing health insurance for the many Mass residents, uninsured or underinsured. Last year, I've been humbled to work with and be partner with the Health Equity Compact, of which Juan mentioned. lifting up and advocating for, crushing and dismantling systemic racism in healthcare for our populations and for lives. I want to thank every single partner, ally, friends in the room and on the panel, the moderators, and obviously extremely thankful to the HPC and all the staff that worked really hard to bring this event to fruition. Looking forward to it and many others. Thank you.
Good morning, everyone. I'm honored to be part of this panel this morning. My name is Carlos Capas. I am the Chief Behavioral Health Officer at Lynn Community Health Center. For those of you who do not know a little bit about Lynn Community Health Center, we serve about 42,000 patients, approximately 70% of which speak a language other than English. A little fun fact about Lynn, we actually started as a community mental health center. And as our founders began to identify the needs of our community, they started to expand the services to primary care and extend it to other areas that they identified in the community. Today, we actually serve our patients and we provide primary care from all ages. We provide behavioral health, dental, vision, and social support services to all of our patients. As in my role, I oversee a significantly large department, but one of the things that we're also proud of that we are embedded, integrated fully into our primary care teams. But not only that, we are actually physically located in 17 of Lynn public schools, providing behavioral health therapy and psychopharmacological services. And as it relates to a lot of the workforce, we are similar to what Andrea said, we do have historical collaborations with academic settings, such as for master's and doctoral level students. And we are really honing in on the fact that we want to create a pipeline to increase the workforce, but also look at how do we diversify the workforce depending on our patients' needs. So I'm looking forward to sharing some of the insights from the report, which I'm happy to hear that conversations continue to happen, but also to hear from you.
Hello, everyone. I'm Andrea Bresnahan, and I'm the Executive Director for the Nursing Council on Workforce Sustainability. So we are a council that was formed basically because the Healthcare Collaborative in 2019 decided that we needed to take a closer look at the nursing workforce. We don't have a nursing center in the state, but the Nursing Council represents the work that a lot of the nursing centers are doing across the country to address our nursing crisis. We have 24 members on our council, and two of them are represented here on our panel today. The Health Policy Commission has a seat, and we are working very closely with HHS and EOLWD. And we have the full support of 4Health Consulting, which is at UMass Chan Medical School. So it's been great to work alongside with all of these professional people in looking at ways that we can help sustain our nursing workforce. My background is from the Florida Center for Nursing. I've worked as a nurse educator. I've worked as an administrator at a nursing school. I've worked in the ICU, and Florida definitely has been facing the challenges that now Massachusetts is facing. So if there's any way that I can be of assistance, and I'm so proud and happy to be calling myself a Massachusetts resident now. Thank you all.
Thank you. Thank you. So we have an amazing panel, and I'm going to start with the first question, and I would love for all of you to answer. So we've just heard an overview of HPC's report and findings on the state of the healthcare workforce in the Commonwealth. As we know, this is a rapidly evolving crisis. I want each one of you to share a reflection or an additional insight, or even an example of the challenges we face across the healthcare system, including how trends may have evolved in the last 6 months. So who wants to start?
I'll start with a reflection. I think through COVID, we realized that mental health is extremely important for not only our patients, but for the people doing the work. At South Shore Health, we created a well-being program that focuses on well-being for the employees, not just our patients. In a time where the workforce is primarily female for nurses, a lot of daycares were closed, but they are still responsible for their families. The daycares that were available were nowhere located near Weymouth, Massachusetts. Actually, one of them was in Stoughton and I timed it one day just to see, is this challenge real? And it would have been over 40 minutes of a commute each way. And it didn't align with the shifts of the nursing shifts. So I think as an organization, we have grown and we see other organizations grow to really think about the mental health and how we can support our colleagues. Doesn't always mean therapy. Sometimes it just means kindness.
So, thank you. I think that just to sort of emphasize the urgency and the shortages, we have an urgent need to hire 8,000 additional workers. And what that means practically is that half of the Commonwealth's nursing facilities are not meeting the state's minimum staffing requirements of 3.58 hours per day. It means that there are extraordinarily challenged in terms of our workforce is having to work overtime. And yes, there is an increasing reliance on temporary nursing agencies, and it's been well documented regarding the cost. But what it does to staff needs further discussion. It just decimates morale. And for the patient, is wildly disruptive to patient care. Pre-pandemic, we were very focused on the gold standard of consistent assignment. That's not possible when you have strangers taking care of strangers. So Julie's right that there's a lot to talk about regarding temporary nursing agencies. But most recently, we sent a survey to our members, and this is shocking and quite unfortunate. We'll probably give Steve a little bit of argita when we disclose that currently our staffed occupancy is at 93%. So that means that for discharge planners, for families trying to have choice of skilled nursing facility, accessing a skilled nursing facility, it is exceedingly difficult. So I would say that that's sort of new from this report and the last time we had a chance to talk to HPC. So we need to hire.
If I could also add to a little bit of what Tara mentioned. Yes, our long-term care members, our CNAs, the members that work in the long-term care facilities, working, imagine working a shift, but having half the staff be temporary, and having the burden of showing and orienting every shift. And so we are well aware of the challenges. We document, we advocate and continue to advocate through the ways that we do as 1199. But I also want to share, the particular challenges to the folks working. And I would say it's the workers in acute care facilities across many different facilities. These unfilled vacancies usually mean that as a worker, you're taking on additional shifts on yourself, whether voluntary or oftentimes mandated to work additional shifts beyond your shift. And you can imagine the immense strain on families, physically, emotionally, for parents, canceling your time with family. And so, the impact is one on the patient, it's one on the worker, and I would say the community. And so I also wanted to just lift up that, unfortunately, the report is it's unfortunate but not shocking, where we represent nearly 80,000 workers across many of these categories, if not all. We see the disconnect every day. I'm looking forward to speaking to kind of these beacons of hope through our training and upgrade fund, and the opportunities to break barriers and, looking for ways every day to break barriers with that. I will also say that there was a quote, actually it was more of a phrase that came to mind, a phrase turned book, by the way. Nothing about us without us. And it came from the disability oppression and empowerment movement. It is now a book. And I raise this because I truly believe, and I know we've seen evidence of this, the workforce also has a voice to the issues that they're seeing on a day-to-day basis. The direct workforce, if placed in a setting where their voices are respected enough and brought in enough and given a sense of trust enough, I believe, and I've seen this, can also add to the solutions, the resolutions, the projects that could lead to us moving closer to understanding and really breaking and fighting through these challenges. I mean, I can't speak to any more challenges than my fellow panelists here. But I also know that there's voices that are eager to get in the room that oftentimes left out of the room.
If I may. No, it's nice to hear. A lot of the things that are coming up that similarly I've been thinking about, wondering about, and seeing how we can work. But I actually want to reflect on a couple of things, not only the report, but two of the comments that the audience made. As far as the report goes, it's really nice to start seeing that on the mental health and behavioral health field, we're really trying to figure out how to gather data to make sense of our profession and our idiosyncrasies and the specifics of how complex our profession is. And hopefully I'll get some time to share with you some of those difficulties that we've had, because it's not similar to in other professions. As far as two comments from the audience, where I was very pleased to hear, is the questions around a diverse workforce. We heard from both that in terms of historically and even before the pandemic, we have struggled with recruiting, retaining, and even training mental health professionals to provide services. And I will even double down and say to those who actually speak another language than English. And needless to say, the uniqueness and the difficulties that for those folks who speak a different language other than English and then come from different cultural backgrounds, how difficult it is for some of them to experience or have the opportunities that some of us may have had to come in the field. So I really want to highlight and thank those that are really, such as the Health Equity Compact, that's really making sure that we really address and highlight and be explicit about these issues, but also look at it as an opportunity to change. And then the other piece that I wanted to highlight is often in the report mentioned it from many of the profession is we are looking to enhance and evolve our workforce. But guess what? We can't do it if our license, if our mentors, if our licensed professionals are not getting the support that they need. So in mental health, this is even more complex because there are so many differences and so many different professions that different pathways to get independently licensed in order to provide services in these community health centers. And even further, how do we allow for all those licensed supervisors or mentors to provide this support that our workforce needs to even diversify it? How do we actually build upon it and ensure that our trainees get the support they need as they learn and come into the our workforce? And lastly, one of the things that was also pointed out in the report is the delayed in care. We really need to recognize that these folks that we're training, they're the folks that are seeing our most complex patients because they're the folks that come in, the staff that are coming in and addressing the demand. So we have delayed care for mental health services, and we are prioritizing those patients that need the most care. But the demand and our capacity mostly lies on those new coming to the field, those that are training. So how do we actually build those supports that are needed so they don't get burnt out, that they actually receive the support that they need, not only clinically, but culturally, linguistically, and in other areas. So I think this report's really allowed me to kind of reflect, but I think most of all, the comments from the audience really kind of highlight a lot of the things that we're struggling as a community health center.
Our story in home health, home care is similar to, consistent with what's been said. I think pre-pandemic, the industry was growing. I think public sentiment is trending toward wanting to receive services in the home. And then it was sort of exacerbated by the pandemic and a sort of public health reason for it. And so that is just compounding our existing workforce issues before. I think, what we're seeing in 2019, 49% of home health agencies were turning away referrals. That number is now over 70% of home health agencies across the nation turning away referrals. How this is playing out in the field, agencies are just simply shrinking their service area. They can't find nurses to go to different areas, so they have to shrink their service area, and it's resulting in access issues. I heard from a provider the other day who since January has interviewed 150 nurses and not one has accepted. The payment models we have are just making it difficult to compete in the field. And then, like Fellaine had said, and Sharon as well sort of alluded to, we're looking at this holistically. Yes, wages and benefits and training are a priority, but what is the emotional well-being of the workforce? Particularly on the direct care worker side, emotional well-being, financial instability. I think we're starting to see in the last 6 months, wages have gone up pretty significantly for the workforce, but is it really resulting in additional services being provided? I think that the wage and benefit cliff is really getting played out pretty quickly, where workers are almost pulling back their hours as they make more money so as not to lose their benefits.
Thank you. I mean, I want to talk a little bit about the council, but I want to talk a little bit about what Dr. Kappa said here. We have an opportunity in Massachusetts like no other state. I mean, we saw the data. Look at our baby boomer population here. I mean, we have a distinct advantage of knowledge, years of experience, professionalism that we can tap into. I mean, I get that our baby boomers don't want to work 12-hour shifts anymore. I don't, but I'll come back and work 4 or 6. I'll come and mentor the next generation. I'll do whatever I can to help because I'm a nurse, and that's what nurses do. We care about healthcare. And so, we need to figure out ways to tap into our retirees. And I get, we should let them take cruises. Absolutely. We should pay for their cruises. When they come back, let them help us. Exactly. And then you'll give us 4 hours a day, right? I mean, we're helping you, you're helping us. And back to the work of the council. And I know you all, when you heard that there was only 24 seats, you were thinking, why can't I be on the council too? You can. We have 6 committees. We have a data committee, which the Health Policy Commission and all of our agencies that collect data have seats on. We're looking at these bigger issues. We're looking at how can we track the travel data? Well, the National Forum for State Nursing Workforce Centers has a member from every state that participates in how to deal with some of these issues. So we're proposing meeting with all of our big travel companies and getting the data from them. Wow, big idea, right? So, I mean, I think we can work together with other states on this. I think we can work together with all of you in the room and our different council members. We have a clinical committee that looks at clinical placements. We have a student committee that talks about diversity and that end of the pipeline, bringing students in. We have a faculty committee that's working on our faculty shortages, and we have a workforce capacity committee that's working on way more than you care to know. So please reach out to me in the future and help us with these issues.
Thank you. Colleen and David, I have to always put my 2 cents in there, and I have to put my 2 cents about Worcester. We have one of the highest overdose mortalities in Worcester. The Latino community and the Black community is the one that suffers the most with that. And trying to find a clinician, a behavioral health specialist to work in the Latino community or to work in the Black community has been incredibly difficult. And I know you couldn't put the data of how many clinicians of color we have, but we don't have those clinicians. So again, talking about equity, what communities are suffering through this process. And when we talk about our school system, they hire their own behavioral health people. So they're taking our behavioral health people from the community into schools, better benefits, better everything. And again, increasing our shortages of behavioral health people. I'm going to give a shout out later to what we're doing in Worcester when we talk about the next question. So all of you have been on the front lines of the workforce crisis. Could you share some of the specific actions or initiatives your organization is taking today to address challenges in your workforce with your members? And the follow-up question, well, I'll ask it afterwards.
I can start. That's all right. So some of the actions that we've have, and this is actually precedes me being at the health center. We have a long history of collaborations with academic institutions. So master's and doctoral level students have the opportunity to actually rotate and do field placements at our health center, not only at our school-based health centers, but also in our integrated teams. I think where we're shifting and we're really trying to focus on, and thanks to the Mass League and a lot of other initiatives that are happening, to really focus on providing opportunities for BIPOC students and trainees from different cultural backgrounds. So given that our patients are unique, our communities are very diverse, we really want to ensure that we mirror our workforce that provides care for our community, so that we mirror our community and we ensure that. So these academic institutions are really putting a lot of effort into doing that, but we're really trying to enhance how do we also look upstream in terms of providing opportunities for trainees and behavioral health students in that. So hopefully later I can share a little bit more about that. What we're also doing is we're trying, or we're looking to expand our peer support services to really help us understand how do we train paraprofessionals, or how do we train peer support providers to not only reflect our community, but really address the issues that are unique to our patients, to our communities, but that go beyond the scope of care of providers themselves. But how do we do this in a collaborative manner and team-based care manner? So I think as far as building on opportunities to really expand on our collaborations with academic institutions and looking beyond just providing field placements, but really being explicit and intentional around how to recruit and train providers that look like our community.
We've been lucky. The undersecretary mentioned a significant amount of investment from EOHHS for home and community-based service workers. There's a large grant fund that just went out and has been awarded to several home and community-based providers. I think a lot of providers are looking at grants to help implement technology to help improve workflow efficiencies for the workforce, telehealth, of course. There are also training programs that we've seen. The Home Care Alliance was awarded a grant that will use a program from New York that is an aid mentorship program. So we will be training upwards of 100 mentors of existing home health aides who are existing home health aides, veterans, and they will be trained on how to mentor new hires, because one of the largest problems among new hires, and that leads to turnover, is particularly in the field. When you're out in a home, you're alone, you don't have a team, you're not in a facility. And so the idea of making a bond between an existing worker and a new worker and trying to make them feel like they're on a team, professionalized. And so we're seeing a lot of different investments like that.
I can't wait to learn and borrow from that, Jake. So great work.
Yeah.
I'll say that we're an advocacy organization, so we spend a lot of time advocating with lawmakers and the governor as to how best to use data that we collect. And this presentation and report from HPC will be invaluable in educating certainly policymakers and lawmakers. So want to first and foremost thank the legislature for their support across the board of elder care workers and healthcare. There has been significant financial investment in nursing facilities, particularly for workers. So we've been able to grow wages by over 25%. So advocacy is something we do, but then we also learned through the pandemic that peer-to-peer learning is enormously helpful. And so we're bringing together in a collaborative HR directors as well as administrators to share what's working and what is more challenging. So we're certainly talking about well-being policies. We're talking about flexible scheduling, which is enormously difficult in our setting. So if anybody has tips on successful models of flex scheduling, that'd be helpful so we can have that 4-hour baby boomer come work in a skilled nursing facility. And we also are working with lawmakers to file legislation legislation and support living wage. We have supported a living wage for our workforce for countless years and want to say thank you to certainly Senator Sear as well as Chairman Lawn for filing that legislation. We also, it was documented in the report that we established and worked with members to operationalize a new position, which is a must-have for any pipeline, which are these resident care assistant positions. We similarly feel that upskilling our CNAs to become medication aides, as happens in 35 other states, would be enormously helpful from a diversity perspective, as well as you're taking on more mentorship and training and moving up the career ladder. But also it frees up a nurse who's currently having a director of nursing who's currently doing a med pass, or nurse supervisor who would otherwise be taking an admission from the hospital. She instead is doing med passes. So that's a way in which we can, certainly through training, which we have available. Our DPH uses a CNA certification vendor. They have testing for med techs available on their platform. So there's lots of, I think, ways in which we're trying to internally advocate and externally advocate on behalf of residents, families, and workers.
I'd love to take the time to speak to the 1199's Training and Upgrade Fund, which was highlighted and showcased in the slides as well. So the training funds has been what we see as the most effective way of dismantling racism. In its conception back in the 60s, it was the vehicle used for community members of color to be trained and get into healthcare, where it was not an opportunity for them, where there were no abilities for them to participate or to work rather. And so right now we have currently 41 employers within the fund, all across the state, all across all of the different care teams that we represent. I want to share a worker story and then speak to the pieces of the fund that have been enhanced since this worker story. Jonaid, who started at Cape Cod Healthcare, Cape Cod Hospital, he actually started in March of 2020. This year, through partnership with Cape Cod Healthcare, 1199, and the Training and Upgrade Fund, she had the opportunity to enroll in a certified nursing assistant program at Cape Cod Community College. She did that while obviously keeping up with her family obligations. She worked 2 jobs and did that while English was not her native language. She speaks Portuguese. It wasn't easy, but she did it. And she says, this is just the beginning for me. And thanks both the employer, Tough, and 1199 for supporting her dreams. Jonaid is one of many. But what I want to highlight is a couple of things. The Training Upgrade Fund, it's a resource that, from the minute you come in to work, you're able to get one-to-one counseling, one-to-one career discussion with folks that, literally all they do day in and day out is think about not only critical positions that are needed, but also what's the best way for our workers to be placed into those positions and what schooling and advancements are needed. Jonaid did not see a bill when she went to school. Because of our contract and our partnership with public higher ed entities, she was able to go to school and not see a bill. Now, these are things that are being talked about in the state today. It's a realization with the training fund. The services range from, free educational and training opportunities, financial assistance for undergrad outside of public higher ed, even, private. We've seen CNAs become nurses. Then from nurses become nurse practitioners. We've been able to help them with college and exam preparatory classes. I mean, it goes on in terms of the opportunity and the access to workers that traditionally would not have either of those. Just speaking a little bit to the apprenticeship program that was specifically highlighted. We currently have expanded that program to include CNA apprenticeship, phlebotomy, and there's a pilot happening, a multimodality rad tech pilot as well. And so, there's constant work being done to, figure out where the need is and how to place workers and position workers to meet those needs. When I heard about the mentorship and the need for mentors, as well as some of the challenges that mentors have, one of the things, and I think it's key and important, is that it's not enough to find training to provide the classes, but we as a union also negotiate with the employer for the mentor themselves. The ability for them to see an increased wage as they're providing these services. And then the ability for backfill of work so they can actually, mentor in a way that's responsible. And so, between the student, the mentor, the program, the classes, and then ultimately access to clinical hours, there's a partnership that I think is a model for like all stakeholders to really filling positions as we see. And I'm also looking forward later to speaking to a little piece of the immigration opportunities as well.
Thank you. So I'm actually, so the next question is to, how would you, what would it take to scale up your initiative within or beyond your organization? I'm going to start by saying that we certainly need some of that input in Worcester. I think we're the forgotten city in a lot of ways, and a lot of stuff is centered around Boston, and we need to think about the other areas, surrounding areas. But we looked at our behavioral health, lack of behavioral health for communities of color, and actually the city in partnership with UMass Med School have started, this is our second year of bringing 10th, 11th graders to really to train them about behavioral health, where we're talking from an addiction counselor all the way to a psychiatrist, and to be able to bring that up to fruition. We have like 30 people. They're getting the experience of going to college. They're getting the experience of all the different things that can happen in our community. And ultimately, when they say, what would it take to scale up your initiative? Money, that scholarship piece is truly the important piece. I think we should be paying for all their colleges for to be able to become any type of behavioral health care specialist. But I'm going to leave it up to you guys. What do you think?
Money.
Yeah. I'll
Money.
double and triple down on that. But I think what you mentioned too, and I think what you, Felina, are saying is it's what we really want to do. We're trying to figure out how do we look upstream, taking 11th, 12th graders, training, like telling them about what it is to become a mental health professional is what we need. Provide that social capital, people of color, mentoring people of color to actually do the work and learn how to do the work. But what we find is also when we're looking upstream, we have incredible opportunities with a lot of our partners and stakeholders that are giving us money to provide loan repayment, to provide salary supplements. But I think when we look upstream, how do we take those 11th and 12th graders and pay them to go to school, pay them a livable wage so that they can actually graduate and not be in debt, not have to worry about providing support for their families, and actually becoming what they want to do and provide the support and the care that our communities need. So I think in order to scale, we do need the money, but we need to look a little bit more into how do we put in place mentors in the community? How do we allow to pay for those trainings, not only at the advanced training or advanced academic levels, but also taking them earlier on. So I love the work that you mentioned in terms of UMass and as well as you with the union, and how do we actually mirror that in such a complex system currently?
In addition to funding, I would say partnerships are extremely important. There's been many mentioned today already, and you're talking 11th and 12th graders. Our organization has partnered with schools in the community to participate in career fairs as early as 4th grade. So over my career, it was only the seniors got to go, and then it was the 8th graders got to go, and now as young as 4th graders. And also start to talk about pipeline strategies. You don't become a nurse overnight, but a nice entry-level position in environmental services or transport. And that leads to a different partnership. South Shore has partnered with Jewish Vocational Services to carry some of the lift in these programs. So the organization alone doesn't handle all of the screening and all of the what it takes to make sure they have the language skills that they need to support them in professionalism and being on time, talk about transportation, and really help people have all the skills that they need when they enter the healthcare profession. Internally, we've taken a lot of our support services, such as a transporter who was, it was quote unquote just a high school job, and I really identify that they're fabulous with patients. How can we help you move to the next level? As an organization, we also nearly doubled our tuition reimbursement and really publicized that. We also I won't say tackle, but really connect with our senior nursing students. We place over 1,000 students in our organization over the course of a year and make sure we don't lose connection with them before they depart to graduate. They're excited. So in that moment that they're excited, we do meet and greet. We let them meet our senior leadership team and really connect about the culture of our organization and how we can support them moving forward. So funding and partnerships.
Should we go on to the next one? If we want a healthcare delivery system that delivers equitable outcomes for all residents of the Commonwealth, we know that who comes in the workforce matters as much as how many come into the workforce and where they go once they're there. With that in mind, can you speak to any efforts your organization is making to build a diversity of the workforce, or to policies that would support expanding the pipeline or would support workforce diversity through advancement?
So I'll jump in because this is my favorite question, yet I have the least delightful response because we need help. And we know we do for the reasons that I said, that 63% of our frontline staff are people of color. But when you look at our supervisors and leaders, they're not. And so we're very grateful to many in this room for supporting what the governor filed in her recent supplemental budget and the undersecretary spoke about, which is the CNA to LPN program, because we believe a strong way of addressing this is through upskilling our direct care workforce. We learned through our massive campaign relative to vaccination is that when we talk and trust people that look like us, believe what we do, we succeed. So I think that that's one way in which we believe strongly and passionately that we need to invest in lifting up those that are at our frontline staff. It's a necessity from a workforce perspective, but also from an equity perspective. The other area that we are quite pleased with is actually the work that David highlighted that Chia and Director Peters are doing in their workforce survey, which begins to ask these questions about ethnicity and diversity, not just for all staff, which I think it does, right, Lauren, but also for the leadership. And it's through that data that we become more accountable And I hope David will have me back in a year and say, Tara, what are you doing? And we want your help actually in making sure that our leaders reflect more of their frontline staff. So thank you.
Absolutely.
I'll just go quick because I totally agree and I thought it was a perfect answer, so I don't think I have much to add. Our workforce is similarly made up in addition to the leadership. And so, like Tara said, pathways. And I think there's a comment in the report that I was really glad the way it said clear pathways, because yes, there are pathways, but they need to be clear to the workforce. What are the opportunities you could have by coming into the field? And I also think for a long time, we've talked about career ladders going from a home health aide or a CNA to a RN or an LPN. I think that's all true, but we also have to embrace the caregivers who like to stay in the roles that they have and train them and make them more competent in their roles, or also offering pathways to, if they want to become a scheduler or a clinical supervisor. It doesn't always have to be from a home health aide to a nurse. And, you know, I'm at fault too for saying stuff like that, but.
In our organization, we have partnered with our foundation, which is the philanthropy portion of our organization. And they have found donors who are would like to direct their funds specifically to scholarships to help first generation students or diverse populations. So we're actually naming a few scholarships this year that will be directed toward those populations.
Yeah, I think back to the money issue. One of our problems when we first brought the council together was how do we support all of the agencies and organizations out there that don't have grant writers, that don't have the ability to apply for this grant that's due next week at 5 o'clock at night on Friday. So we brought, we built a grants committee and brought a lot of experts together to try and figure out ways that we can support one another. We don't have a grant writer. If we want to get funding for that, that'd be great. But we do have the support of our project managers, and we've been able to build we're building a list of all the grants in the state and where they hit that kind of nursing highway. We don't like to call it a pipeline because nurses come in and out right all over the place. So we call it a highway or a roadmap. But where are these grants hitting? Where are our gaps still? So we're looking at that right now. The beauty of the council, we have a lot of minds, but it can take a little longer to get a single answer. And we also were able to build a data resource catalog that looks at all the data in the state. It's available to all of you. It was accepted by the National Forum as a document that they're going to use throughout the country now. So it was that in depth. We had a lot of work with, worked with the Health Policy Commission and some other members to create that document. And what we found we're lacking in the state is our nursing licensure supply data, which hadn't been analyzed since 2015. And then we are also lacking any nursing education data. So it's really hard to build this beautiful picture with only parts of the data. So we're working on these right now, and we're hopeful, but I think, just making sure that everyone is educated about what's really necessary to paint the picture and to help us with these longer term problems is helpful too.
So, Tara, I want to thank you, and I'm going to disagree. I thought that was a delightful response. I think what you did is make some of our challenges explicit, which is our leaders and our supervisors often do not reflect the workforce that we're trying to build. And I want to speak to that because I think it's incredibly important. And with the low resources that we may have right now, what we're doing at our health centers is we are allowing and providing space, administrative time, reducing productivity expectations to those independently licensed supervisors that are training and mentoring our current staff, those students, those interns, those unlicensed providers on the path to independent licensure. And what this has allowed us to do is to free up some of the time for them to actually do the work, build supports that best help our students, our interns, and our unlicensed staff. So for example, by doing this, some of our supervisor groups have created cultural reflection groups for students and independent or unlicensed staff that are struggling with issues that are related to speaking a different language other than English, such as conducting therapy in Spanish and documenting in English, and all of the repercussions that being someone from a different cultural background provide. So at our health center, we have definitely committed to providing. So I want to say something in terms of historically and currently, this is not something that community health centers do. And I think other community mental health centers do not do because it's not funded. We still rely on a fee-for-service system that is what keeps our services going. And often our supervisors are doing this outside of the work hours. And a lot of the things that this this does is meet individually or in group supervision. They have to co-sign notes for our students and our unlicensed staff in order for us to get reimbursed for those services. So what we have committed, because we believe by building a workforce, it really help us in the long run in many other areas, including cost. So we're really trying to build on our workforce pipeline programs, our academic partnerships, but internally, we really need to invest on those mentors, those supervisors that are doing the work and are helping us build the workforce. So I think this is one of the things that we would like to talk further in terms of how do we provide support and funding for it.
Thank you. I'm going to add a comment on both of you at the end. I think that I think we have to think about the bias that does exist in our community. So we put somebody of color in leadership positions and we scrutinize them to the nth degree. And we don't support them. And that's a huge piece. And I think you also talked about grants and the ability to write grants. I think if we look at our agencies in our community who are Black and brown, they get the least amount of grant, least amount of support, least amount of just even being looked at to be a participant in places. And so being able to pick them up and be able to raise that is incredibly important. But also, I think the experience that we've had, I know that people of color have had going through medical school, we're the token Black and brown people. And so that sits on our shoulders. Imagine somebody who's an administrator, and we've had this in Worcester, where everybody is looking at them. They may make one mistake and everybody's on them instead of supporting them. So I think that bias has to change. Okay.
I just wanted to
Yeah.
add, actually, I purposely waited for the end.
Oh, did I take that from you?
Hold on, wait for it. I know. In addition to funding, there is an umbrella that, I would be remiss to leave this seat and not speak to. And it is the ability for workers to form their union. And I speak to that. Because one, the wages of a healthcare worker cannot be minimum wage. That's our priority. Second, we have to create and establish a dialogue for workers and management. And our union has shown that workers of color can sit at a table and speak for themselves and speak to the issues in a way that no other collective group can. And so, I add the ability to form a union as one that I think is extremely important and critical. I also just wanted to share that in terms of data and our ability to understand how deep the issues of inequity is, the Health Equity Compact, as part of its omnibus bill, also we have advocated for a structure in our state government to create an Office of Equity that would be that beginning space that holds all of this information. We get it from the AG, we're hearing it from HBC, but there needs to be a space that holds all of that, and it flows into every part of the cabinets, that flows into every part of our economy, workforce, so that we can truly understand and tackle the issues that matter. You mentioned in terms of the folks of color and the lack of opportunity and where that is, because it's not a mistake. For a long time, it hasn't been a mistake or by chance that we have not been able to enter into spaces to speak for issues that hurt us all. And I think that we're at a point in the state where we can change a whole frame, a whole narrative by focusing on equity in a way that we haven't, that we have disparately in pieces, but instead we build it in one space together. And so I share that. And then there's just one quick thing on the training and upgrade fund. Last year, we were able to advocate for a legislative earmark that did something that, quite honestly, there's too many returns. We were able to advocate for $1 million legislative earmark that we use to augment the benefits and use for wraparound services for workers that are going to school or training or what the education benefit that they're using. And so you can imagine childcare paid, transportation paid, technology. So any areas of access that may not necessarily be the classes themselves, we've been able to find a way to just pay. Thank you.
Okay. As identified in the HPC report, alleviating current healthcare workforce challenges will require coordinated, sustained, and well-resourced interventions in the short, medium, and long term. We have several important state and federal policymakers in the room. What is the one policy solution you would recommend to them that would meaningfully alleviate one of the workforce burdens that has been identified today in the short term, impact 1 to 2 years, medium term 2 to 5 years, and long term 5 years and more?
Who's gonna fight to start this
The one.
I could start. I mean, I don't think I could sit in this answer or say this answer without talking about rates and reimbursement, because it does always come down to wages and benefits. We need a reimbursement structure, speaking to home health at least, that can support obviously a livable wage, an adequate wage, a competitive wage, and then a benefit structure that includes training and upskilling and opportunities and pathways, and getting policymakers to understand, again, specific to home health, that when we get a rate for a visit, that rate has to cover the wage, the benefit, all the payroll taxes, but it also covers the supervisory staff. For a home health aide, it covers the RN supervision, it covers office staff. And so after all of that, how are you left over? How is a provider left able to make an investment in training, in a training program or student loan repayment? So we really need, just for an example, Medicare pays about $150 per nursing visit. Mass Health pays $90. So we have a dynamic in home health where Medicare is subsidizing Medicaid. And as Medicare looks at that, Medicare is saying, why are we subsidizing it? The profit margins for Medicare are very high, but the overall margins for a home health agency are not as high because they're using that Medicare margin to subsidize the state programs.
Well, I think if I go last, everyone gets a count. Is that how? Because I said I loved the equitable question. This one was hard because it's so difficult when you're talking about such a massive problem, crisis, to have one solution. So I'm gonna piggyback Jake's rates, because absolutely, I think we've heard this morning that funding is central. And I think even HPC's report talks about that as a solution for direct care workers. The other I mentioned was the certified medication aid. That's accessible to us. It can happen. And so that would be just a critical upskilling opportunity for our workers. TNSs, I have a lot to say about temporary nursing, but I don't want to be sort of a one message pony here. So I'm going to talk about also the great need for childcare services, transportation, and housing. So all of the other secretariats and policies that need to be addressed to support our workforce are also very critical.
Sure. So I just wanted to lift up, the question with the one policy, my goodness. I will say this. I mean, I know that the wages for workers, healthcare workers, it's not enough. We saw in the report what was costed out as, the wage to live for a single person without children, $21.88. However, to, have healthcare workers working and making, $16 an hour, $17 an hour, less than that in some places, it has to be addressed. Our healthcare workers are not only working under the strain of staffing shortages, but caring for themselves by relying on safety net programs, multiple jobs to make ends meet. There's an equitable thing to say around allowing folks to care for themselves and care for themselves in a way that allows them to live and work. I also just want to lift up I think that and this is a stakeholder conversation around lifting up the stigma to working in healthcare and really crushing it through a statewide effort that goes back into the communities and adds and speaks to, coming back into healthcare, because so many have left. We can speak to the shortages and, bringing in our, respective members and respective workers back in with different programs. But I think that this is something where we can actually work jointly together in terms of creating a massive marketing campaign that brings workers back into healthcare and kind of removes that sting of, because I remember back in the day, if you had a job in healthcare in my family, I mean, you were regarded as the one. You were the person, right? Like you star next to your name. And so, a lot of that, and, obviously in some ways, rightly so, during the pandemic, it pulled folks away. Folks ran out, retired and ran out. But we know that, for our patients, for all of us, there's a time, and I think the time is such as this where we speak that we jointly bring folks back in. And so, launching a Care for Massachusetts kind of recruitment campaign is one thing. And then, having some workforce recruitment retention support supported by a hospital and health center, like just a healthcare workforce training and apprenticeship fund on the state level to support work that looks and resembles like the training funds across our state.
Yeah, so ditto to the wages across the board. As it relates to behavioral health and community health centers, I think this is particularly important. And we all know that to an extent, and I think behavioral health has been underfunded for quite a long time, but I think there are a lot of initiatives that are really tackling our ability to enhance our workforce. What I do worry about, this needs to be an immediate, short-term, but also long-term solution, because the people that we're not seeing now, what's going to happen to them in 10 years? The kids that we're not able to see now for behavioral health and therapy and provide that support to the family, what's going to happen to them? What's that going to create in the long term as they become young adults? So we really need to focus on how do we enhance and increase our wages. So invest in us. We promise that we will also make sure that we tackle all those other things that we're really focusing on healthcare, such as reducing total cost of care. As a local, somewhat policy level, one thing that I will admit, as a mental health professional that fairly knows that some of the system is very complex, and this has to do with state licensing board requirements. We are seeing from our students graduating from master's and doctoral levels and getting on the path of licensure, it's becoming a little burdensome to become independently licensed. And what this does is we're talking about the strain that's placed on the supervisors and the mentors. And as much as, we can wait and provide the support, there needs to be a revision of those requirements that right now often really delay our ability to enhance our workforce, particularly a diverse workforce. I will just briefly mention that not only is it challenging for someone whose English is the first language, but those who actually English is a second language struggle also with meeting requirement for sitting for the exams for licensure, and also struggling to pass those exams. So that's a Puerto Rico would say it's another $20, but that's a different subject. But I think how do we look at our licensing board requirements to provide flexibility to be able to supervise across all disciplines? Right now, psychologists can only supervise psychologists to meet full requirements to sit for a licensing exam. Same for social workers, same for mental health counselors, and same for licensed and marriage families and therapists. So how do we provide flexibility to be able to supervise across disciplines and not put an extra burden on our independently licensed social workers, psychologists, and mental health counselors? And also, how do we create easier alternative routes to those who are essentially more disadvantaged in passing licensing exams? So I think with our initiative with providing support and an extra administrative time for our supervisors, we really need to look at that. But as far as local policy, can we start relooking at our requirements for state licensing board as a way to really create a faster path for those folks that to become independently licensed and join our workforce? Thank you.
I could not say it better than the experts on this panel. The Nursing Council does support all of these requests.
So I agree. I also, certainly the increase in wages is important. I certainly agree with the licensing requirements. I also want you to think about some of the people that are out in the community. So community health workers. What we learned in COVID is that we don't have access to the community. We don't know the community. That's why people did not vaccinate. That's why people didn't get COVID testing. That's why we had the lowest numbers in communities of color. I think what we learned from there is that we have to go out into the community. Community health workers are incredibly important to go out into the community and let us know what is happening in the community. We pay them nothing. We pay them minimally. And so we lose our community health workers. Recovery coaches, we all know that addiction is something that we can't reach. It's not a police thing. It's not it is truly people with lived experience that can go out and work with people and get people into treatment, but not only into treatment, but be able to support them. I have an example of somebody that I want to hire who is excellent at what he does as a recovery coach. We can't hire him because he can't afford to pay his family. So 21, and we increased our rate to $20 an hour. That's not enough for people to be able to survive. So the essential things are the people who from the hospital, from the city in the sense of health and human service who go out into the community, they need to be able to support and be able to get paid a livable wage so that they can survive. And lastly, I'm just going to say about homeless, because we have incredibly rising rates of homelessness in our community throughout Massachusetts. And we have no behavioral health that goes into shelters or goes anyplace else to help people. So if we don't help people recover, we kind of say, well, a permanent supportive housing will bring all the services to them. Well, if we can't find the housing, why aren't we bringing it into the places where people are? And how do we treat people so that people who are homeless can recover from whether it's addiction or whether it's mental health issues, that we put them into stable treatment? So that's it for my 2 cents. Thank you. Thank you all. And questions? Questions from anybody in that? Oh, come on. It was a pretty good group here.
Hi, I'm Cindy Friedman. I'm the Senate Chair of Healthcare Financing. You guys did an incredible job of laying it all out. Really important to be able to sort of get it in one space. So I think I've learned some things and I've reheard other things that we know about. I think that there are lots of us in the legislature that are well aware of some of these issues. I think we have to give some credit to the government for the work they've done over the last 2 years in terms of the money that they've spent and the support that they've given. I think you have enormous amount of support. Certainly, the Senate president was the person who said all community colleges should be free, and she meant it. And I'm sure we're going to see something coming out of that. So this is all really valuable. I guess my comment and my question is, the state cannot do it all. We have gazillion, million, trillion dollars in our healthcare system, and it ain't going to the right places. So what do you see from your level that we could do, that HPC can do, so that we get more money in the system going to the right places, meaning primary care, of which, by the way, 700 matches were made last week. 35 were for primary care, 35, okay? How do we continue to get money and get support to our community health centers, which we should have, as far as I'm concerned, one in every community, right? How do we make this shift? Where are you seeing the bottlenecks, not necessarily from the state, but from the entities or from where are the insurers in all this? With all due respect to the wonderful anesthesiologists, we're still paying them huge amounts of money. We're not paying our primary care and our nurses in certain places so much money. So we need to, as a group, think about how we make that shift, because we spend $9 billion on mass health. We try desperately to take care of people. We can't raise all your rates, we don't have the money. So how do we do that? And I think that's really, there's these individual things we can do, which you've pointed out, and I think we can look at, but the bigger issue we have to look at, and we have to all get on board with, so that we can speak as one voice, is how do we move the system to the places that make the most difference in health and taking care of people. So I guess there's not a question there, but I just feel like we really need to have that very difficult conversation while we're doing these short-term things, because we'll never get out of this. The state will never be able to pay $30 an hour for a, at a long-term care facility. We'd all like to, but we just don't have those funds. So I appreciate your work enormously, and we've got to focus on some other pieces. Where's pharma? Where's PBMs? Where's insurers? Where's, so that's my
Thank you. That'll
Thank
give
you.
us more to think about at night.
I just
we're
have a
here for.
comment related to that. And in all the work that everybody's doing, it's so important for everybody to come to the table. I think my ask would be, in the spirit of professional development and utilizing our internal and external experts, is that we always think about who is at the table, and are the people doing the work able to save or redirect or guide or educate us to say where those funds should be going, because they may be able to help the solution.
Any other thoughts?
Oh, no.
How about healthcare for all?
There's thought.
Thank you very much for this important conversation. My name is Katie Murphy. I'm the president of the Massachusetts Nurses Association. I'm a critical care nurse at the Brigham and Women's Hospital, and I spent the entire pandemic in a special pathogens unit. So I never have to wonder what our members and the direct care workers are going through. I live it 12-hour shifts every single solitary week. I might not have a question either, but I do have maybe 2 points to make. And one is, it's very interesting, looking at the executive summary. It mirrors some of the information that we received in our annual survey this year, that nurses across the Commonwealth and across the state do not have enough time to provide the high quality care that our patients deserve. You saw that, and we see that as well. This is a structural issue, and it is we have plenty of nurses, as you pointed out, in the state. They just are not willing to work in the circumstances that exist right now in our hospitals. And we have, over the last several decades, presented you with those solutions. And that is to provide the nursing staff that patients require at the bedside. You also identified the very real issue of workplace violence. And the data probably doesn't exist because nurses and all healthcare providers up and down the spectrum are assaulted every single shift, 24 hours a day, and it's not being reported. That is also driving healthcare professionals, and not just nurses, away from the bedside, contributing to this lack of professionals at the bedside. We have it is within our grasp to change that right away. It's very interesting listening to the solutions you were offering, and I think every single one of you identified funding as a barrier to reaching the goals, to finding those solutions and putting those solutions into practice. Yet again, this session, the Improved Medicare for All bill has been introduced in the legislation. It is Senate 744, House 1239. We would save, according to Professor Gerald Friedman, economist at UMass, at least $9 billion in the state of Massachusetts alone annually if we were putting those healthcare dollars at the bedside, really, or in the clinic, or in the outpatient setting, in the home care, where patients want them, rather than to the third-party payers. Again, this is within our grasp. We could pass this, and we could solve the issues that you have dedicated your lives to addressing and trying to find those solutions. So really, it's within our hands right now, and we certainly look forward to working with you on achieving these goals.
Amy. Hello, Amy Shea with the Health Foundation of Central Massachusetts. Glad to be able to join Dr. Castile in bringing the Central Mass perspective to this discussion. I'm also a new member of the Health Equity Compact. My question is whether there are opportunities to move even farther upstream and to think outside of the healthcare sector. I agree completely that there's a need to increase reimbursement rates, but we're constrained by the very high cost of living here in Massachusetts. So are there opportunities to think about solutions to address social determinants of health, like housing, transportation, education? Because otherwise, many of the innovations that have been described today are really constrained by those conditions. Thank you.
I fully agree.
Next. Any other thoughts? Thank you.
Thank you.
Thank you all.
Yes. All right, as we reset, if folks want to grab a drink or a snack, we still have a lot of food left. Please feel free.
Believe me. Oh my goodness.
My notes.
As you see, I got more notes.
He's gonna stand and lord over you there. All right, well, first of all, I just want to thank our panel one moderator, Dr. Castiel, and all of our panelists. Such a fabulous panel. We learned so much. Thank you so much. Now turning to our second panel, this panel is focused on what's next. What does the future hold for the healthcare workforce? Recommendations for Massachusetts to promote resiliency and innovation. It is my honor to introduce our second panel moderator, HPC Commissioner Tim Foley. Commissioner Foley is the Executive Vice President for 1199 SEIU, which is the state's largest union of healthcare workers. He's been there for almost 2 decades, 17 years. Started out as a political director. Commissioner Foley is also a very long time member of the HPC's board. He was first appointed in 2016, reappointed again by former auditor Suzanne Bump in 2022. Obviously, Commissioner Foley represents the healthcare workforce on the HPC's board of directors as a leader in a very important labor organization in our state, and also personally has a very deep and broad understanding of the many challenges facing the healthcare workforce today, both the system and its workers. So thank you, Commissioner, for facilitating this discussion today. Let's get started.
Good afternoon, everyone. Afternoon, almost close. I was going to say it was a great panel discussion, and I'm really pleased that HBC is holding this important conversation, and for the stakeholders and folks in the room here today to hear about some of the issues that we all know we've been experiencing across the healthcare spectrum and try to drive to some solutions in areas that we can work together to find common cause. I was also sometimes hoping to turn off my camera for a minute and get up and walk around when I was in person. So, we were able to take some time and stretch. It was a great conversation for the first panel, and good luck to all of you to try to repeat what was said before. And we're going to take points off if you were to say anything that's been said prior. So it all has to be new and innovative if we're going to address the issues of the workforce crisis and care crisis that we're facing. So first, I just wanted to have each of the panelists just introduce themselves, a little bit about their background, and then we'll get into the conversation. Steve?
Thanks very much, Tim. And it's good to be here with all of you, and it's great to be in person. And I really want to thank the Health Policy Commission, particularly Executive Director Seltz, Chair DeVoe. The workforce report is so critical and so timely. And the leadership of the commission to now look at workforce as a top priority is just so important to those that are on the front line. As my colleagues know, those that are working in our healthcare facilities today, COVID has not ended. They are still battling in crisis every day and have been for more than 3 years. And as the rest of us want to go on to all of the other things in our life that are critical, and why wouldn't we, right? We missed weddings and funerals and graduations and proms. Our healthcare workers haven't had that luxury. They're still in it. And we need to remember that as we think about this. And a little thank you to the state. I know Senator Friedman said it. Chair Decker's here, Chair Lon's team. We would not have been able to survive the last 3 years without the support of the legislature, the administration, and government. Their work in partnership with all of our leaders and workers in healthcare was simply miraculous, and why we didn't see in Massachusetts what we saw in other parts of the country. And for the folks that I'm fortunate enough to be seated with today, 1199 SEIU and Tim's partnership and leadership, and MMS, and worked most closely with their team in Lois, but Dr. Stinson here today, and the League of Health Centers, and Michael, my dear friend, who we talked almost daily, the Mass Nurse Association, and Julie's leadership, and making sure that her workers had what they needed to do their job as effectively as possible in trying times. And Lydia Conley, who has been a leader in the behavioral health crisis from the association. Folks that are here today are part of the reason why we're able to have the conversation about the future. But it's important, I think, to note the past for just a second, and how we got to where we are. And those folks that have been working every day to make sure that they keep our loved ones safe. And I think the most miraculous thing about our frontline workers is, as was said earlier, the job is so incredibly hard. And then they go back and do it again, and they do it again, and they do it again, and they do it for our loved ones. And that is simply heroic. And that is something that I think we ought to remember as we move forward on the discussions of how we evolve and innovate for the future so that we can protect them and protect, most importantly, the patients that they serve. So thanks, Tim.
So I want to also thank HPC for doing this work as a frontline worker. I'm an emergency medicine physician at Boston Medical Center. This is very critical to the line of work that I'm in. And it's very encouraging and inspiring seeing now that this is being put at the forefront, the minds of everyone in leadership positions here, till we actually will now be able to start thinking about how to make effective change. As we have probably heard, a lot of these issues were really ongoing prior to the pandemic, but then exacerbated a lot more to where now we're in this room having these conversations. So thank you. So a little bit more about me. I'm here representing Mass Medical Society, emergency medicine physician at Boston Medical Center, and practicing almost 15 years now. Also serve as the president of the New England Medical Association, which is a group of Black physicians in the New England area, where we create voice and work towards bringing voice to the Black physician in this area. I've also worked in the setting of FQHCs as medical directors, and most recently served as assistant director at the mass vaccine site at the Reggie Lewis Center. So I've been at pretty much every touch point in this workforce conversation. And I think I need to add a little bit too. I am the daughter of a registered nurse. My dad, who served his whole career as a nurse, and had many conversations with him at the time of the pandemic of him entering back into the workforce. So I am very well versed in this workforce and has probably touched me in every aspect of my life. And last thing I want to say is that these conversations are not only important for the workforce, but also for every one of us in this room, because it will impact how we even access care if things are not addressed in an appropriate manner. So just not just for workforce, but also for each individual person in this room as well.
Hi, everyone. My name is Julie Pinkham. I'm the executive director of the Massachusetts Nurses Association, RN by background. Been with the association a very long time. Let's put it this way. I didn't have gray hair, and it's not all because of COVID. I have gray hair now. I'm really happy to be on the panel today and to working with folks for solutions. I do want to echo a comment that you just made, which was, it's, I think, extremely important to understand these issues did not evolve with COVID. These issues have been percolating and evolving over the last 2 decades, and we have been trying to grapple with them unsuccessfully. And the pandemic, I think, really put a final straw on the camel's back here. And now we have mass exodus, and we can't afford to wait any longer. So, you know, it's be important to discuss the issues, but I think everybody here understands if there is not action to back it up, we are going to be in very serious difficulties. As far as the association, we represent 25,000 registered nurses and health professionals across the state. Primarily registered nurses, and primarily the bulk of our membership is in the acute care hospitals in the state, but we also represent VNAs, public health, school nurses as well. And again, I'll stop there. Looking forward to today's conversation.
Good morning. I'd be remiss if I didn't start today by expressing deep sadness for the loss of the Honorable Mel King, who in 1967 became the director of the New Urban League of Greater Boston, where he championed issues of workforce development, training, and fair wages. So as I've spent much of the morning on radio and TV interviews talking about his legacy and his mentorship for many of us who do this work, I just want us to reflect on his legacy this morning. I want to express my gratitude, as many others have said, to the Health Policy Commission, staff and board, for the tremendous work that you do. We love being in partnership with you to talk about these issues of primary care, community health, and making sure that these are integrated in the work that you're doing. The Mass League is an association of 52 community health center organizations across the state, serving over 1 million patients out of 300 plus practice sites. It is a work that many of us in this room who are health center leaders, who are listening and watching, feel like we are, as the Speaker of the House told me once, we're doing God's work. I want to start with this. In the work that we do, both at the League with health centers and in the work that many have mentioned today around the Health Equity Compact, there's been a theme that's been recurring in a lot of our conversations, which is pay now or pay greater later. I just want you to sit with that for a second. Pay now or pay greater later. And when I think about COVID and what we experienced over the last 3 years, we didn't pay heed to that pay now or pay greater later. that if you don't invest in primary care, it should be no surprise that they're in your emergency room and in hospital stays. If you don't invest in public health, it's no surprise during a pandemic that the public health infrastructure wasn't there to respond to the crisis during that time. It's no surprise that if we don't invest in the workforce, a diverse workforce, as SEIU often lifts up, then it's no surprise that we're lacking people who community can trust, that they see themselves in when you're trying to get them to get tested or vaccinated. So I think we have to really heed that calling around pay now or pay greater later. How do we now implement that with workforce training and development programs that are inclusive? How do we, as my good friend Juan LaPera lifted up earlier, invest in the immigrant community and even those undocumented who come to this country with skills, with talent that we're not tapping? And as a young kid who grew up in a housing projects in Roxbury, Lenox Street housing projects, how do we tap those young Black and brown young people across this Commonwealth who have talent and who could be that next driver of innovation in healthcare, that next nurse, that next doctor? We're not doing that, and we never really have. So I think there's a challenge for us today about how do we invest in primary care, community health, diverse pipelines, and I look forward to being part of the conversation.
Thank you.
Thank you. I'm Lydia Conley from the Association for Behavioral Healthcare. I want to join my colleagues in thanking the Health Policy Commission, Director Seltz. Director Seltz, I'd ask for future panels that I not follow Mike because it's a terrible act. Or it's a fantastic act.
And by the way, it's unfair because three of us went to law school together, Steve, Lydia, and myself. We all graduated law school.
We did, yes, same class. Thanks, Mike. I think maybe unlike some of my colleagues here, I should explain what the Association for Behavioral Health Care is, because behavioral health care can be a little bit squishy. So we represent 80 community-based mental health and addiction treatment provider organizations. So I have noticed that behavioral health is kind of morphing into mental health, but we include substance use disorder when ABH is talking about it. Our member organizations are safety net providers, delivering behavioral health services to kids, youth, and adults. And so when Mike is talking about investing in primary care and, you know, pay now or pay later or greater, or Stitch in Time Saves 9, I would include safety net settings like community mental health as well. Our members, just for context for behavioral health, we deliver services in the state contracted space. So we deliver mental health services, for example, to adults with serious mental illness that are funded by the Department of Mental Health, or kids who are in congregate care that are state agency involved. So mental health services there. But we're also in the insurance-based delivery space, which has been most of the discussion today. And so our members deliver outpatient mental health clinic services, or basically the entire continuum of substance use delivery treatment services. So we're straddling both spheres of both healthcare and human services. And I do want to acknowledge that the legislature, to the point of some of my panels earlier, has been kept both sides of the House afloat during the pandemic. So there was supplemental funding. The economic development bill included funding on both the healthcare delivery side and tremendous funding on the human services delivery side that funds services for the workforce in the Department of Mental Health funded programs. So we would not be here today, and we would not be serving as many people as we do today without the support of the legislature. We do, like our colleagues, though, continue to hear about the workforce. It is a crisis. I agree the urgency. I agree with Julie on that for sure. We continue to hear of access delays, access and care delays continue. They are getting worse. And it is driven primarily about workforce. I know we're here to talk about solutions today, and I'm looking forward to having that conversation.
Great. Let's give this panelist a big round of applause. I think it's going to have a great conversation here. So again, we just want to start off now. This is the second panel of the day. We've heard the report on the great presentation to kick us all off, to kind of level set. We heard a great discussion from the panel before about some of the ideas and impacts that this care crisis is having from their perspectives. And so I just wanted to give an opportunity for this panel to just respond to kind of what you've heard so far, what the report says to you, and then we'll try to get into some of the systems approaches. We've talked a lot, and the report suggests, and we all know this, about the backlog of care in hospitals and discharge rates and behavioral health boarding and the ER. We'll get to some of that and want to hear thoughts and comments about that. We're going to talk about some of the impacts this is having on some of our providers, particularly safety net providers across the Commonwealth. Some of the barriers. I want to hear what folks see about barriers for entry into the workforce and training for healthcare workers. how that impacts potentially diversity goals. So we'll try to have some of that conversation as well, and then really dig into solutions. That's what we want to push this panel on, is thinking about what we've heard earlier today from the report, what we got out of the panel before. Let's really dig into some of the solutions. I think Senator Freeman kind of laid down that question for us, that we all know state funding is a part of the solution. It can't be the whole part. So thinking about that as well when we get to the solutions part. But I do think we should start with some level setting of just kind of what have you learned from the report, and what's new, what's not new to you, and what did you learn from the panel that can help inform the conversations about how we're going to think about this as a systems issue, the barriers to entry in the workforce, and then just general overall solutions to what we know is the biggest issue facing healthcare and healthcare delivery, which is the workforce. So however we want to go, to each of you, just some general reflections of what we've learned, what you got out of the panel, and then we'll go from there. So I don't know who wants to go first. Michael, you can't go first, I guess. Remember, you got to go last on all these questions now.
Well, I'll jump in and just, you asked 174 questions there, Tim. But we'll try to just.
No, we're going to get to the other pieces.
You know, for me, and I think, Julie predicted we talked about this earlier, it's about this contract labor problem. This is an absolutely unsustainable model, and it's going to bankrupt our system. So if we care about any of the other things that are important to us, we have to solve this problem. So in FY22, we spent $1.5 billion in contract labor, a 600% increase. For example, if FY19, prior to the pandemic, we spent 300 million. From 300 million to 1.5 billion. And if you think about this for a second, it is remarkable that we've allowed this to happen. So you can have a worker that's side by side with another worker, and they leave on a Monday, and then on Tuesday, they're rented back to the same facility at 400x, 300x, 200x, depending on demand, right next to that same worker they were with the day before. What does that do for morale? What does it do for the ability to invest in the workforce that is giving their heart and soul, the FTEs that are there and have been there for their career? We have to put some guardrails around this. It's absolutely unsustainable model that is going to make the affordability discussion that the commission wants to have, it's in conflict with that. We just can't focus on the other things until we figure this out in this moment. And it's going to take government intervention, and it may be federal, to help us with this.
Other reflections, general reflections?
This is like a follow-up. I'm happy to. I think in general, yeah, the contract issue is a big issue, but I think, again, I want to remind people to look back earlier than the pandemic, because keep in mind the temporary workforce issue was a regulatory change that occurred during the pandemic. It was predicted to do exactly what it did within 3 weeks. I had a vivid conversation saying, don't do this. The only thing I have going for me right now is the nurses are all in the same foxhole together. As soon as you do this, there's no light at the end of the tunnel. What's to stop a nurse from leaving, coming back to his or her same job and saying, I'm not working weekends. I want the first 2 weeks in July off, and I'm not really liking this night rotation much. The core staff is left holding the bag, and now there's animosity between people that formerly worked together during a pandemic. So, it was predicted to do exactly what it did. So I do agree that it has to go away. But often what I fear is, and I think a lot of the data validated what nurses have been saying years prior to the pandemic. With that, keep in mind that the slow changes that occurred. So when, I forget who was on earlier talking about continuity of care, that means so much to nurses when you arrive on a unit, that you know the core staff that you're working with. It is very much important because you have different levels of expertise. And to deal with the type of stress that you have on a unit like that, there's things that you will not talk about at home. It's just not appropriate dinner conversation, okay? But with your colleagues, you can get through the stress of that moment. You can get through that crisis that occurred. Well, over the years, what's happened is what used to be predominantly full-time staff went from 60% full-time to minority full-time staff, majority part-time staff. We used to have per diems that were an adjunct casual workforce, 10 to 15% of the workforce. They're now 25, 30% of the workforce. That's why I say these issues have been percolating long before. Now, I wouldn't have predicted the latest assault to make it even worse than it was to add in now the temporary contract workforce. So I think we have a lot to unravel to get the nurses to return, but do not lose sight that the return means I get to return to a group that I consistently work for in order to make it, once again, you talk about, which is mission centered. You can't get that if you don't even know the person that you're working with.
I want to add, jokingly saying that I feel a little bit like the invisible dinosaur. I know a lot of the conversations right now are around nursing staff and direct care, and hasn't been a whole lot around physician workforce. Just in this meeting, which I know there's work being done, but I want to mention that because of the shortage in the nurses and the structural issues that are happening there, they directly impact the care that we provide as physicians. And I want to mention how critical that is to how we provide the quality of care to patients, and also how they will access us as physicians. In addition, I just wanted to mention that trends that do happen in the nursing field and other fields or specialties within healthcare are also trends that similarly happen within the physician workspace as well. And speaking specifically to emergency medicine, I know someone had mentioned the match about a week and a half ago. We had about 555 unmatched positions in emergency medicine around the country. That is the highest we've had, I think, since the creation of the specialty. And I don't know if that's a canary in the coal mine, and maybe this is the next conversation we'll be having at the next HPC meeting around the attractiveness of medicine to people actually going in as physicians and nurses. And I think from this report, that's one thing that I took away, that, maybe the specialty of medicine isn't as attractive as it used to be. And we're starting to see that in how residents are matching into their specialties. And I also say that because we've been speaking a lot about primary care and emergency medicine being kind of that catchment space for those who can't go to their primary care physician. If these trends continue with how we're matching and putting physicians in emergency medicine, we're going to see another crisis down the pipeline for physicians in emergency medicine that are going to be available to care for those people who are being lost in the primary care space. So I just wanted to throw that out there, and just things that kind of this report has highlighted for me.
Yes, we'll fight over this. Yep. Yep. So I guess I'll start. I just want to bring forward, as part of this discussion, I was glad to hear Dr. Castiel talk about this as well, substance use disorder, making sure that we don't get, that doesn't get lost in the behavioral health discussion. So alongside the mental health crisis that is in the papers every day, there is the ongoing overdose crisis. In 2021, as everyone here knows, there were 2,300 fatal overdoses. That was an 11% increase from 2020. That crisis is evolving. It's becoming polysubstance use. It's very complex. At the same time, ABH has surveyed our members, and we're showing a 24% total position vacancy rate across substance use disorder treatment programs. Beds are coming offline for 24/7 levels of care. 46% of staff in acute treatment services, so that's formerly known as detox, left their positions in the past year. The average wait time to enter residential rehab services in our membership anyway is 34 days. And a quarter of our members reported that it was over 60 days. So significant gaps, hiccups that's not strong enough word, but the care continuum is not really working very well in the substance use disorder delivery system. In addition, on nursing, 81% of nurses in opioid treatment programs left over the past year. So we're experiencing things that I think we've heard from the panel throughout the day. The direct care workforce vacancies are impacting access to care. Nursing is impacting access to care, and of course, behavioral health professionals.
I think a few things. One is, I think pre-pandemic, health centers were experiencing a workforce crisis that we were challenged with. We were thinking about or talking with health centers that were telling us that when they had a vacancy, it took them up to a year and a half to fill a vacancy at a community health center. When we think about the populations that community health centers serve, right? High need, acute care, acute needs of the patients in those communities, high Medicaid, that's devastating in terms of meeting the needs of those communities. To add on top of that, that these are communities with health disparities, higher rates of diabetes and heart disease and cancer. So what are the implications of not having one or two or three providers to provide that care? And then I think about the report, which I appreciated the report pointing out a national statistic, which is our nation's health centers face unprecedented rates of attrition, with 68% losing 5 to 15% of their workforce and 15% losing a quarter to half of their staff in 2021. I reached out. The same rates of attrition are also true for Massachusetts health centers. In fact, just this morning, one health center shared with me that they had 50% turnover in staff since the height of the pandemic. So I think we understand the disruption that causes to have to recruit, to retain staff. When I think about the many conversations I've had and my good friend, Chair Friedman in the room around all of these issues, including workforce, I think there's a lot of interconnected issues here. Rates, providers receiving adequate, fair reimbursement. I think it's investment in both recruitment and retention. And we've done that in this state. I think the legislature and others have credited the state for the tremendous amount of work it did, particularly during the pandemic, to invest in pipeline recruitment and retention. I think much of the most recent investments are keeping people in place. But what does that look like 2, 3, 4, 5 years down the road? As I think about the Globe article that recently came out that talks about the crisis, the quarter or so of providers that are thinking about leaving the profession. So I guess the overall theme is the crisis was here before the pandemic. It's just made worse, and it has real life consequences for the patients we serve. I lift this up in every room I go into around deferred care. And we typically think of deferred care as an issue that patients didn't come in for care. And in community health centers, that's your eyes, your teeth, your mental health, your substance use disorder, or that pain in your side that by the time you come in could be stage 4. All of that. But the real crisis now is the combination of patients getting them back in for care and having a system that can meet them when they want to come back in for care. That is the tsunami we're facing. Redetermination stacked on top of that. It is a scary time that we're in. If we really understand that all of these issues, these workforce issues, has real life consequences on the health and survival of patients in the communities that we're talking about.
Thank you all for that. And I think, yeah, that's why we need to be having these conversations, because it is a scary time in healthcare for patients and for caregivers. And we got to all come together and have these types of conversations. Clearly, the primary care issue has to continue to do the research, which I think David and the commission have said they're going to continue to do. The theme that I got from some of those answers is twofold. One is that these issues predated the pandemic, right? That we knew these existed and they were exacerbated by the pandemic. It's made it a lot worse, the problem that we're collectively trying to solve. And two, and it came out in the report too, when it's something we all know about the interconnectedness of all these issues. And so I wanted to just dig into that a little bit with this panel and just to ask a question related to that. So how should strategies to address workforce issues take these cross-continuum challenges into account? Are there common solutions that different sectors can and should work together to advance? And how are we thinking about working together across all these interconnected systems or individual providers into a system to address this workforce issue together? Are there examples of some of this? How should we be thinking about solutions that address this interconnected issue with the backup at the ER, which has been mentioned? According to the report, in June of 2022, 50% of patients admitted to the ED had mental health conditions, remained in the ED for longer than 12 hours. In September 2022, 200 acute care patients waited over a month to be discharged to a skilled nursing facility. We heard earlier about the workforce challenges there. Those are just some of the statistics and facts that came out of this report. So how are we thinking about solutions that address the interconnected nature of our healthcare system?
I'm happy to start. So, when we're talking about this, the cross continuum challenges, our experience in the behavioral health safety net is that we're competing for a finite and really diminishing workforce. And we would be, I think this is getting exacerbated as we're developing new programs. So behavioral health in particular, let's have new programs in schools and have them in shelters and have them in primary care. So it's creating additional demand for behavioral health expertise when we don't have the workforce to deliver that. So we would be recommending payment and policy strategies that encourage partnerships rather than building out new services. And so there's a precedent in the Mass Health space where Mass Health required accountable care organizations and community-based entities to partner together to deliver care management services to individuals with complex behavioral health disorders. And so we'd like to see more of that. So it's an assertive policy and payment response that, rather than creating the need for more bodies, was leveraging existing expertise. I would also commend Mass Health. But partnership is hard, collaboration is hard. And sort of to promote that work, they included funding for technical assistance for ACOs and for the community entities. There was workforce training dedicated to those initiatives. There was additional, there were projects that supported the integration and communication between the healthcare entities. So more of that to support leveraging of the workforce would be greatly appreciated. I think integration also is really great. And we know there's plans for more integration into primary care. I think we need to see more of that leveraging of the workforce rather than creating the need for more additional people who don't yet exist. So instead of different roles, we're leveraging the community provider to come into the primary care practice rather than now we have to hire someone away from the community provider, and it just exacerbates all the problems that we're talking about.
And I'll add, from Massachusetts Medical Society, where we represent over 20,000 physicians in the Commonwealth, the report that Michael mentioned earlier, we recently published a report on physician burnout. And we've been doing a lot of this work for several years now, trying to assess burnout and provide resources to our providers around burnout. And one biggest thing that we think is really contributing to a lot of providers leaving the workforce. So we mentioned about 25% of them are considering retiring or even reducing their hours significantly. So we know it's not an issue around number of physicians per population. It's more so around what's driving physicians out of the workforce currently and better understanding that. And so by publishing this report, we're able to kind of see what some of the burdens are that are contributing to burnout. A lot of it is, I think a lot of people of color mentioned racism as one of the main contributing factors to what's causing their burnout in their workforce. And also not feeling wanted or that they matter within their workforce. All of this on top of COVID has really contributed to really driving people to think about how they restructure their careers. And I think from Mass Medical standpoint, we've had a very strong advocacy arm where we will likely continue based off the findings we find in further research that we do. One thing that we are working on right now is, and have worked on, is prior authorization and reducing that administrative burden, which is another contributing factor, I think, across the board and more primarily in the primary care space. In addition to also doing a lot of legislative work alongside our legislative colleagues around increased reimbursements for telemedicine. Prior to the pandemic, telemedicine was not reimbursed very well or even allowed in certain spaces. So it's opened a huge door for us to increase access and enable providers to kind of include some flexibility to their practice styles as well. So we'll probably continue working in these spaces to kind of figure out what's contributing to this burnout and to our members leaving the workspace, to make sure that we're continuing to have supportive environments where they're feeling heard, listened to, supported, and wanted to continue doing the work. I mean, we all enter into because we want to help.
I didn't like this question, so.
Next.
Well, I think in part because it can mean so many different ways, and it touches on a million different issues, right? So how do you really go after it? I mean, when I try to narrow it down, I think in many ways it's about incentives, right? I mean, right now, if we went back to the 90s where we started getting into this debacle with, deregulating healthcare and putting all the scorpions in the bottle, and we're going to have this and we're going to have that, none of which, by the way, I think worked, but nonetheless. So here we are, and I think everything is incentivized by reimbursement, and sometimes I think that there's not enough oversight on incentivization on public health need. We want to measure ourselves as if we're looking at it from a public health perspective, but we don't run our healthcare anything like a public health. We just don't do it, and it's an afterthought. So, a clear example would be like the determination of need process that we go through, where we watch a service close, the Department of, Public Health says, yes, that service is essential. And then we write a piece of paper about how they can deal with that by going to the hospital 20 miles away to get that service in a voucher. And then 3 years later, that hospital closes that same service. And then we go through the same process and it's essential. And then we write another piece of paper that says they can go to the hospital down the road 20 miles away for that service. And what we end up with is maternal child health deserts in the South Shore, behavioral health deserts. We have lots of pediatric closures and, we're scratching our head going, why? Well, because we don't have a public health system. We don't do our healthcare like it's public health. So why do we look at it like we're measuring it that way? So I guess I would sort of really take a big step back and say, what do we want out of this system? And if we're going to do that, then we should incentivize it to act like what we want, not what we have now, which is very much a competitive business model.
I think that's absolutely right. And I think that one of the reasons why we were successful over the past 3 years and coming on to the end of the public health emergency is because that stuff melted away and there was a spirit of collaboration. And so the simple answer to the question is, should be working together on this? Absolutely, yes. I mean, when you look at the continuum, there's no other way to do it if we're going to be successful. If they got to an emergency department, maybe they unnecessarily bypassed the health center or they didn't get a primary care appointment. Senator Freeman's earlier question, maybe they couldn't find a primary care appointment, but it's too late. They've already gotten there. Now they're waiting in the ED and they can't be admitted to a med surg unit. Maybe because there's a staffing challenge, maybe because there's 1,000 stuck patients that are waiting to be discharged to someplace else, which is a complex problem that includes prior auth, but also transport, also finding a bed, also being able to have staff to do the discharge properly. So there's all these other challenges on those 1,000 people that are waiting. So the backlog in the ED, then you have 568 patients today waiting for behavioral health placement, which takes 800 workers to bring those beds back online. 20% of our beds are offline today. So we have enough mattresses. We have enough people to staff those mattresses. So if we don't think about it all as one, we're absolutely destined to fail. I think the easy answer is yes, we should do it. To get to the hard answer is, how are we going to do it? How are we going to build it so we don't go back to that competitive nature that may have existed before? And when you walk up to the person that's been waiting 8 hours in an ED, frankly, they don't care about any of this. They want to know that they're going to be seen, that they're going to be okay, or if they're there with a loved one, that someone is going to come out and take care of their mother, father, friend before it's too late. And that's the moral challenge that our healthcare workforce is facing right now, trying to do the best job they can for the patients that are come through the door that we don't have enough workers to be able to manage.
Maybe one of the greatest pleasures in my many years of doing this work, 16 years at Blue Cross and now 15 years at the Mass League, was co-chairing Governor Healey's healthcare transition committee. What I thought was fascinating is as I was facilitating some of the conversations, is I had a flashback to years of these conversations, even Deval Patrick's transition team, Governor Patrick, where some of us staffed that transition team and helped to write the report. I went forward into Senator Kennedy's office, the late Senator Kennedy's office, where he had invited some folks down to talk about health reform in Massachusetts. And of course, these workforce issues came up. And I think about solutions to some of these issues. I always think of Jim Hunt's, my predecessor's phrase that we're always repackaging the Tylenol. The reality is none of this is new, right? We talked in the healthcare transition team about a moonshot approach to the workforce crisis, that we need to invest in that next generation, in that workforce. So I think about the many aspects of the conversations we've heard today, both investments in internships, paid internships. We have this issue particularly that impacts Black and Brown and poor communities, which is Black and Brown and poor communities can't afford to do unpaid internships. So how do we invest in that? We're doing some really great work with MGB as a health center association around that space, and particularly in the behavioral health area. Well-being, as we talk about that today, to partnerships, working with Mass General Hospital on some groundbreaking work they've done on provider well-being, and then translating some of that work to community health centers. So there's a lot of things that exist already, but they're not to scale. We're not investing in them. During the pandemic, I would be on the phone with DPH or our former secretary, And I would say we often call this a war against COVID-19, but we're not all in the war room. Right? We're doing this in these episodic silos of what we could do. And I'm like, why am I not in the room with Steve and Hospital Association? Why am I not in the room with Mass Medical Society, Healthcare for All, and MPHA and others? Why are we not sitting in the room and figuring out what we can do collaboratively and what we could do that really is that moonshot approach to addressing some of these issues? I would say in the workforce issue, we still have not done that. We're still not sitting in the room, and it's repackaging in Tylenol because these ideas exist around how to recruit, how to retain, how to do it in a diverse and inclusive way. But we have to invest in it. It goes back to my earlier phrase, pay now or pay greater later. If we don't do this, there'll be another crisis that'll exacerbate everything we're dealing with now, and it'll make it even worse. And I'll say this last thing on diversity because it's such an important topic for me, that I would say, as many of the folks in this room, I think about Manny Lopes at Blue Cross and Juan and Rosa from Tufts, Jeffrey Sanchez, and we talk about only 5% of the doctors in this country are Black. 5. And if we think that only 5% of Black community is qualified to be a doctor, shame on you. That means that we didn't allow them to be the best selves, the best of themselves, and go to the right STEM programs and to make it into a medical school and to become that physician that we needed them to be. So shame on us that we have a workforce crisis, that we basically relegated the talent of being a physician to a small demographic of people. I don't know if people catch how ridiculous that was. And that too many Black and brown folks had to go to Meharry and Howard University and HBCUs to get their education because predominantly white institutions, even here in Massachusetts, aren't matriculating, aren't graduating future physicians of color. So we have a challenge. We can do something about that immediately and how we recruit and graduate these students.
Thank you for that. And I think what I'm taking away from this clearly is better, more integrated plans and approaches through Mass Health. The issue of what I heard from you, Steve, was recapturing the spirit of how we approached COVID, to work together and break down those silos, to create those spaces and rooms where we can bring providers together, try to problem solve together. And then clearly the issues related to a diverse workforce and how we're really thinking about that and capturing and not repackaging the Tylenol. And when I was hearing a lot of this, because we've said a lot about this is pre-pandemic and this exacerbated it, and we've talked about these issues before. I guess my question for all of us, but particularly for this panel, is how do we break that cycle?
I think I want to speak just directly to the workforce diversity piece. Like, how do we break that cycle? Because that's been ongoing. And I do want to mention, I went to Meharry Medical College. But I think, and Michael mentioned about 5.6, it went up 0.6. It was 5.2, it's 5.6. 5.6 of physicians in this country are Black. I work at a facility where we see somewhere around 40% of the Black community in Boston, and I am probably a handful of Black physicians in that department. I don't know if the demographics here in Massachusetts even match nationally, because I don't think we're capturing that data appropriately, but I think there's a lot of work that can be done in the part of retention and retaining. And I don't know so much too if it's just having access to educational programs, but more so the barriers that we face as Black physicians of even climbing the trajectory of going through a career of becoming a physician. You don't make a physician overnight. We just don't wake up, go into a certification program. This has to start from the grade school level. And there's tons of research out right now talking about how leaky that pipeline is. Falling out, students who may be interested in medicine fall out as young as like middle school or high school. And I think these are opportunities that we can do. And another thing that I noticed during the pandemic, there was not a lot of involvement in the community, just at the superficial level. And I think there's some opportunities for us all of these organizations in this room to think about how we can collaborate more in the community space and collaborate more at the educational level to strengthen these pipelines. So more Black and brown people who live in Boston can matriculate through the healthcare career journey and stay in Boston and Massachusetts and continue to contribute to the workforce. So once you enter into medical school, the debt is astronomical. A lot of students come out with $500,000 debt, and they don't come from families that can support them through their journey. So yes, you're accruing all this debt, but you still have to live. You have to pay your rent. You have to put gas in your car. You have to eat. And even at the resident level, we see residents struggling, even though they're making a dismal amount of money to live in Boston, carrying $500,000 in debt. They're still having the challenges of like just living and wanting to like just be good residents. You know, you have these other social determinants, even as a resident, that are prohibiting your journey of becoming a good physician. So I think this is an opportunity for us to think about ways. I know I heard a lot of loan repayments. I don't see a lot of loan repayments for physicians, and that's critical too. We see a lot of Black physicians come to Massachusetts, but we also see them come, train, and then leave. So I think we need to think about that if we're going to be serious about the conversation around workforce and the diversity of the workforce that we're bringing into Massachusetts.
Thank you.
Maybe
Others?
a quick comment on how we can address that. I tend to lift up the model of the Health Equity Compact. You know, I was around as a staffer at Blue Cross when health reform was passed, Chapter 58. I call myself a kid. I wasn't really a kid, but sitting in those rooms with many of the architects developing that legislation and being a staff person there and listening in, and that room was predominantly white men. And I remember being at Faneuil Hall, which some of us in this room were during the signing ceremony, and I was thinking about how magnificent it was that right people, right place, right time, right? The health plans willing to go beyond what, quite frankly, nationally health plans weren't willing to do. Advocates like Greater Boston Interfaith Organization, Reverend Hamilton, and Healthcare for All. I mean, right people, right place, and right time. I always said we could go back in time and have to try to do that again. We probably couldn't have got it done because it just took the right people pushing it forward. So I think collaboration now around this issue is really about right people, right place, right time. I know I'm on a speed dial with Steve Walsh. We talk a lot about these issues with the advocacy groups. I want to give credit to some phenomenal legislators, and they didn't ask me to do this, but I'm gonna do it anyway. Representative Decker, in particular, Cindy Friedman, Senator Sear. When I tell you they're on speed dial with me and the staff all the time saying, what do you think we can do? How can we do something about this? How do we address that issue? But I also think they're conveners. And what we need is conveners, people who are trusted and can call all of us and say, hey, come to the table. What can you do? What's uncomfortable for you to push it? I think the Health Equity Compact is an example of that. 65 leaders from various parts of the health system, not just healthcare, coming together because we have a lived experience to try to address health equity, and we don't always agree. And quite frankly, sometimes we don't agree to the point that it worries me that we may break up. But that lived experience is what keeps us at the table to figure out how can we push the next movement of healthcare reform in Massachusetts being health equity. But I think that model works, right? How do you get the right people at the table with leaders like I'm talking about in a room to say, what can we do? And then what will it take us as a Commonwealth to achieve that? I don't know how often I see that with any big issues anymore. We talk in groups and small pockets. So I think if we really want to attack this issue, let's take the report, let's dissect the report, let's get in a room and figure out what we can each do to contribute to that work. I see that as possible.
I do agree that on the issue of convening, I mean, I think you need a prompt. Left to its own devices, people will work within their own silos over their own issue. I mean, it's just, it needs to happen if it's this much of a critical issue. On the diversity, I was struck by the slides. Clearly in Massachusetts, we have a predominantly white female registered nurse workforce. But I was covering in New York City and I was like a breath of fresh air. I'm like, oh, okay, there's diversity somewhere, right? Because it's not in our state, right? So why? But then I looked at the slides up here and you realize that there's so many folks of color coming through the system in healthcare who then don't go beyond become RNs, right? Why is that? You know, I know the 1199 works hard to educate and bring people into the career, which is great, but there isn't there isn't another structure in place really actively doing that. I don't know why that doesn't exist, but I will say this much, I think it hasn't been encouraged. And I think we've really, some of this is self-inflicted injury, because over the years, we have created an atmosphere that has sort of lent the groundwork that if you're a registered nurse working at the best bedside, that's just a step. You know, you really you're not a professional yet until you've taken the next step. You know, and I don't know where that came from. I definitely think that in academia, there was a big push for advanced degrees. I mean, I'm all for advanced degrees, but I also think in doing this, we did a disservice into actually relaying how much of a wonderful career being at the bedside is. And it's unmatched, and there's absolutely nothing wrong with that. And if you love it and you're good at it, we should reward that, we should honor it, and we should encourage it, not suggest that you got to go a little bit further in order to really be something. So I think we own some of that, and we have to change that dialogue.
Others? Steve?
Yeah, I would, I'd agree with everything that has been said. I do want to mention Michael's generational work on the compact and how critical that is, and also the state's work through the leadership of the legislature on the Mass Health waiver, which for the first time has put our money where our mouth is relative to health equity. I think that's an important first step. And we're the only state in the country so far to do that. So there are some important steps that's happening. I'd offer up for the moonshot, we've talked about this a little bit, a Massachusetts AmeriCorps program for healthcare service. Pay now or pay greater later. And it doesn't matter whether they go work with Tara, they go work with Michael, they go work with Julie, just go work in healthcare, right? Healthcare is an amazing vocation. And Healthcare for All right now is doing some amazing work on the redetermination. So when they're done with that, let's use those same door knockers to go into communities of color and attract people to come into healthcare. And let's pay for it. Let's pay to educate. Let's pay to train. Let's pay while you're going through school, and let's pay with a job when you're done. And the payback is you stay in the Commonwealth and you give back as a level of service for some number of years. Same where AmeriCorps was built. Those are the type of ideas that we're going to have. Those are the type of moonshots that are going to make a difference to attract people back into the workforce immediately. And then South Carolina has this great program. You should look at H is for hiring. What's the H for? H is for hiring. So talk about what you can do in the healthcare field. RN my mother was an RN, amazing profession. But so is being a cook. So is being a transport. So is being security. So is working at the front desk. You're all on the same team that's helping to take care of patients every day. So let's talk to the public about that. Amazon has this 30-second spot. I can only work every other Monday. You're hired. You can only work on Fridays. You're hired. You only work on Wednesdays. You're hired. Why have we built so much rigidity into healthcare that we can't figure out how to get people that want to work into the field? So let's think about it differently. Let's approach it differently. As you know from my opening, I am not a fan of the contract labor market, but there's something to be learned from it. There's something to be learned from people that are choosing their own quality of life, their own mental health, their own family over working the way we have created this sector over the last 100 years. So let's disrupt it, think about it differently, and bring people back into the workforce. And let's start by using the foundation we already have. We already have a great foundation in Healthcare for All that did it for vaccination, did it for testing. Now let's do it to attract people into a service program.
And Tim, real quick, just because I'd be remiss if I didn't say this, a key component to solutions and strategy going forward, and we've talked about it even with our hospital partners, is restoring Medicaid graduate medical education program in Massachusetts. We previously funded that in the Commonwealth at $44 million, with half of that generated in federal matching funds. You know, this was in a Chapter 224 report. Secretary Polanowitz at the time had included that as a key component of addressing this workforce issue. And then I co-chaired the state's legislative health equity task force. We included that in that report as well. Another key piece of the puzzle in addressing these issues.
Yeah, I can't say anything more or better than what my fellow panelists did, but I would add some of the stuff that Steve and the panelists are articulating. We're already doing things to the legislature. The infrastructure is there. So we're doing student loan repayment programs. That started with Mass Health. It's being built with the league. There's no reason why we can't scaffold this into, upfront tuition supports, build up the kinds of things that Steve is talking about. Steve's talking about leveraging other infrastructure, perhaps with Healthcare for All or whatever partners make most sense. But we're already doing it. We just need to build on that, and would encourage the moonshot from our fairly solid foundation.
Yeah, I would just add something that 1199 has been advocating for, and Felaine highlighted in the earlier panel, is this notion that workers can't afford to lose pay and employers can't afford to pay for the lost wages. And so how do we come up with a fund that it's available for apprenticeship programs or for a training program that is there for each employer to apply for and get reimbursed for the lost wages for that workforce? Because the worker can't afford to take that day off, and the employer can't afford to pay for someone who's not delivering care on that day. So I think that's another example of how the moonshot idea of a AmeriCorps-like workforce solution could be, and how the state may be able to help and support that. And I would just say, Steve, to your comment about the Healthcare for All canvassers that are talking to folks about redeterminations, many of them are PCAs. They're recruiting home care workers in Springfield and in Lawrence to do that work because they have the relationships in the communities. They need the extra pay. And so the pipeline is already started that you've talked about through this process, because healthcare workers want to go out and talk to community members, particularly home care workers. They want to make sure folks have access to good quality care. And they're spending their time after delivering their home care services to go talk to their community members about making sure that they go through the redetermination process. So that's brings it full circle. I think we've touched on a lot of the questions that I had. One thing that just keeps coming up in my mind, I think it's something I would like some thoughts and reflection on. It goes to an earlier point that was made about immigration in particular, the need for more workers in our state and those that are already here. That one thing that jumped out at me at this report is that the workforce supply has dropped most in healthcare sectors with low pay. Not shocking to anyone in this room. Mostly in long-term care and home care in particular. These jobs, as we also know, are overwhelmingly filled by women and people of color and immigrants. And I know we just talked about one of our key goals is to diversify the workforce. And I guess my question is that goal attainable without significant wage increases and immigration reform to address the issues of low-wage workers in the state of Massachusetts? Can we do it without lifting wages and addressing immigration?
Well, one, I think it goes to the interconnection of all these issues, right? Is it reimbursement so that people can hire people and pay them fair wages? It goes to investment. As a state, are we prioritizing this area and identifying that population of untapped talent as important enough to put those dollars where our mouth is and train them, as Steve said earlier? I think it is immigration reform, of course, and we have limitations as a state because it's really a federal issue that is unlikely to be resolved anytime soon with the divisions that we see down in Congress. But what can we do to make sure that we're doing things as a state that recognize that whether you're here in the Commonwealth, from Haiti or Colombia or name the country, we want you to be working and we want you to make a living, and we want your talent to serve in the Commonwealth. I think there's ways we can do that. I'm not an immigration knowledgeable person in that space, but we need to figure out what we can do outside of the federal government that will create that. The other thing is, and we've talked about it for years, and it's come up many times, the scope of practice. How do we now, and I just had this conversation with the Senate President around scope of practice, how do we now embrace the fact that we need people operating to the top of their license? We need to think differently about scope of practice issues. Just really quick example, Blue Cross many years ago, when we were debating health reform, and I had a chance to facilitate the conversation internally around nurse practitioners having a greater role as primary care providers. And hope I'm not snitching on Blue Cross folks when I say this. But there were some folks
on the record too.
A little on the record. Yeah. They'll appreciate this too. It's a long time ago. And there were some folks in the room that said, no, patients will die if we let nurse practitioners have that role. And of course, there was somebody who was actually a chief medical officer at the time, Dr. Cook, who said, we're doing that now. They're doing that work now. So really, what's the difference? We get very stuck on how we do things. So how can we think about embracing the role that providers have and investing in them doing it to the top of their training and their talent?
Others? Embracing change, I think, is something that I heard too. So as part of this conversation.
I mean, the investment has to be in the workforce that are delivering care to our patients, but it can't be spent then on contract labor and other things that are unsustainable. The reality is hospitals are in a very difficult, fragile state right now. Walk into any one of them. The investment should be in workforce, but we need to, Senator Friedman and I were talking about this yesterday, we need to think about administrative burdens. Where else can we save money? Value-based care, changing the delivery system, delivering care outside the walls of the hospital. We need to do things because if Executive Director Seltz is going to get back to the discussion around affordability, we need to figure out how to be more affordable, but invest in workforce and also stabilize our community health centers and our academic medical centers. And those are three legs of the stool that are really difficult, but they can't happen with what we saw Dr. Arbeck print this morning. That's the real challenge that we have today, because obviously the people that are delivering our care is where the focus should be. And we should be paying them. And Professor Kotler just left. He's done some really good research in this area that there probably post-COVID will be a wage reset and it will come up. But it can't come up to the 600% where contract labor is. And the investment would always want to be to the people that are giving their lives to the facilities that they work in, not those that are coming in for a shift or a weekend or 4 weeks and then going off to see some other part of the country.
Yeah, getting back to actually Mike's earlier point, and I'd add to Steve's point, community behavioral health safety net settings to the settings that need to get stabilized. Strategies that we have been thinking about in terms of calling in to the workforce. So the FY23 budget includes technical assistance for providers serving communities of color to bring them into the delivery system. So we're optimistic that that's going to bring more experts from communities of color into the addiction treatment system in particular. New York State's Medicaid program pays an enhanced rate for many behavioral health services when they're delivered in languages other than English. And we think our state Medicaid program, and Senator Friedman raised the point of where the carriers in this discussion should be considering strategies like that. So calling in a workforce that might be available into the insurance-based delivery system could be strategies.
Just in reminding, when we look at this, that one of the findings that we had was that supply from an RN standpoint wasn't the issue. So it's, we've got different issues going on. And, ironically, Steve and I don't disagree. The contract nurse issue was a bad idea. I don't know whose idea it was. I would like to find that out at some point. But it was a bad idea. But on the other hand, I also want to point out that like the ICN released their report, the International Congress of Nursing released this month too. And I don't know if folks have had an opportunity to read that as well. So it's very telling that the issues facing us here today are facing international. We've had the British nurses out on strike, the Irish nurses out on strike, the places going wild, Canada nurses, everybody, and there's all different reimbursement structures, right? So I would be conscious to think like we can come up with what we want to have as an equitable system and talk about reimbursement, but there's another side of this coin that is being missed clearly, and that is the accountability to the people who are who are the workforce itself, what they want. And I think what we've missed over and over and over again is we are not listening to them. And right now, I would say the trust level of the people on the front line is nil. And I'll give you a very clear example, and I don't want to punch people out on this, but just the reality is it's like we can talk in these global terms about what we like, but here's what's happening today. This week or whatever, I talked to a group of nurses who basically the contract nurses work 12-hour shifts. The institution wants to make sure that they get their ORs back up to speed because they're below where they were. So they want them back up to 140 or 150 cases. Well, contract nurses are 12-hour shifts. The regular nurses are only 8. So it would be much better if we move the regular nurses to 12-hour shifts so we can get all of our ORs in. These nurses have been working under the gun for nearly 4 years now. They have kids, they have everything. We fought unilaterally in 2 weeks, those nurses were assigned to 12-hour shifts. I guarantee you a third of that workforce will be probably out within a short period of time. we haven't talked about this. Norwood Hospital flooded out and closed. All right, we lost all those nurses and redeployed. Only last month, right, Brockton Hospital had a 10-alarm fire, closed down the in-service there. Good Samaritan had over 200 people in the emergency department. We were trying to redeploy nurses. Two things happened. One, it took us 72 hours to come up with a redeployment agreement with area institutions to get those nurses out into the area institutions where we knew that patients were likely being seen. A number of institutions refused to engage in agreement with us. Why do you think that is? They didn't want to have anything to do with the M&A and the union. So instead, those nurses were left holding the bag without a job and trying to find a place to work, and the patients are distributed all over the place. So we really need to look inward on if we're really going to partner and we're going to listen and we're going to do change, then we have to break down some of the silos too and start actually listening to everybody in the room. Least of all is people on the front line. And I know we're going to get to this question at some point, but I'm gonna leap ahead in case we miss it. Right. And that is, Steve knows what I'm going to say here, is over for 2 decades now, the nurses on the front line have said, we need enforceable limits. You know, and you may argue on what it is, but as they said in the Federal Reserve building almost a decade ago, when Speaker Finneran set up a debate on the issue, someone got up in the hall and said, well, if you don't know what it is, you certainly know what it isn't. And I'm saying at some point we have to stick a fork in it. And if we're going to change reimbursements and structure, people are going to know, what is it that is safe? What do I come to when I come to a floor? Because if the institution thinks 6 or 7 is safe and the nurse doesn't, you can put as much reimbursement as you want out there. You can do whatever you want, but I guarantee you they're going to leave. They have been leaving and they will continue to leave. And the supplies tide tells you we have 140,000 of them in this state. Why aren't they back at the bedside? Why did they leave? And some of them, obviously, Steve, I can't blame them. They probably paid off mortgages and, and student debt and everything else with the money. But that we were never for that regulation and we remain not for it. And we have actively requested that there be a mechanism to turn off that spigot. But in doing so, I would feel horrible if we turned off that spigot and we didn't give the relief to the nurses that are the core nurses and what is truly a safe assignment and listen to their voices in that.
Thank you.
I don't think you can have this conversation without having a true reimbursement conversation and figuring out how that structure is going to look. But I think the most critical thing that's been said in this discussion about this question is the listening. And I think that probably is the most critical piece to even why we're here right now, not only for nurses, but other providers within this whole healthcare system. And back to your question about, the direct workers, the CNAs, of course, the conversation about compensation is critical, but I also think they haven't been heard or listened to. And I think because of their position, they're probably at the bottom of the totem pole. And having working directly with them in the emergency department, understanding how critical their role is, oftentimes we just do not listen to what their needs are to understand how we can kind of meet them, work with them. And I would actually argue that they need to be at the table when these conversations are had so we can understand what their needs are in order to address them. Because they affect the nurses, they affect the physicians, and they affect all the other staff within the departments across each healthcare system.
Thank you so much.
I'll jump in on just the listening. So I think the most important issue isn't what Julie mentioned. What I thought she was going to talk about was workplace violence that Katie brought up earlier. I think that's the most important issue. And through a series of listening and dialogue and focus groups, I think that our members had a good conversation with their frontline workforce about what was happening. And there have been some significant supporters in the state on comprehensive workplace violence legislation, including those legislators here in the room. But that's a necessity. Yeah, it was asked earlier if there's data. There is data. Every 38 minutes in a Massachusetts hospital, a frontline worker is assaulted. Now, if you turned on the news a few weeks ago, you would have seen a flight to Boston, person up in the plane tried to stab a flight attendant with a broken spoon, was subdued by 4 things. It was a terrible situation. But I saw it on the Today Show. I saw it on CNN, saw it on MSNBC. Didn't see it on Fox because I don't watch Fox, but I'm sure it was on Fox. 38 minutes ago, there was a frontline worker assaulted in Massachusetts. Is that going to be on the news tonight? So the leadership of our members at least have got together and done a voluntary code of conduct to try to self-regulate this problem. It isn't enough. It needs legislation. We need to treat healthcare workers like TSA agents. Nobody runs into an airport, runs into security. Obviously, there are some discussions around intent, behavioral health patients, other challenges that we face in the hospital, but that's the number one issue right now facing our workforce, and that's achievable today to fix.
Thank you all. I think we are out of time, but okay. If there's questions from the audience, now would be the time to come to the mic.
I have to thank Michael Curry for giving us this segue. I wasn't sure where we were going to fit in. I'm Melissa Crode. I am a certified registered nurse anesthetist, which is one of the 5 categories of advanced practice nurses in Massachusetts. I am the former 2-time president of the Massachusetts Association of Nurse Anesthetists. And now I chair our government relations team because I'm a sucker. And, and so you did bring up, you know what, I should mention that I have 2 tables of critical care nurses who are enrolled in the doctoral program for nurse anesthesia at Boston College and one of their faculty members. So it's been an insightful day for them, learning about policy. I had 2 observations about the study that I was not aware that the advanced practice workforce accounts for only 3% of the workforce, because it really kind of doesn't feel that way to us, but I guess that's a true, but at the same time, we weren't included in the direct care, and I'm curious how that came about, but we can get to that. So the Health Policy Commission did an amazing study and released the results about nurse midwives last January. And we read that with great interest, lots of great stats there that we can see it was pretty much on the mark from what we see. The conclusions that the study came to were related to hospital bylaws, culture, and practice barriers that happen at the facility level. Now, Cindy Friedman and our legislature has done a really great job during the pandemic, and then with the passage of the Patients First Act, all APNs were granted the independent prescriptive authority, which represented the last barrier of legislative and statutory restrictions on practice. But what the Health Policy Commission study really highlighted, it hasn't really made a difference, not one bit. Where the practice barriers are happening is at the facility level due to bylaws, cultural practice, old ideologies that may or may not hold true anymore. But the other thing that is really going to stop this also is you could have the best legislative situation, right? No practice legislative statutory limitations. You could have the whole hospital administration and the physicians all on the same board. But one of the other things that the study showed is that the reimbursement for APRNs is less than. In fact, we had one major insurer just this month announce that they are going to decrease reimbursement for CRNA services by 15%. This would be a service that we provide the same as our physician colleagues. So now we're getting into what are we paying for, right? Are we paying for the service or are we paying for a provider? So that was pretty much, I know everybody wants to go home. But I just, was waiting for the right time to bring up our 3% worth of information. But thank you, Mr. Curry, because I was really gonna slink out of here quietly and the students, but Thank you very much.
Thank you for being here. Thanks for the students for being here. All right, with that, I'm gonna thank the panel. Let's give them a round of applause for the great discussion, and we're gonna invite David Seltz up to close the program out.
New England School Varsity.
All right, well, thank you, everyone. Thank you to our panelists. Thank you to our moderators. This has just been such a wonderful morning and day, and so much great thought has been put into this. And the thoughtful conversations and comments from all of our panelists have just been so impactful for me. I have learned so much. I have learned new things. I have reheard things that confirmed, in some cases, my concerns and worries, but also reaffirmed my optimism for the future. I want to thank the Health Policy Commission Board as well, our legislative partners, Representative Decker, thank you for being here as well. Everyone that is in this room and has stayed for the whole 4 hours, thank you. Everyone who's still online, thank you. This may have been your first introduction to the Health Policy Commission in terms of the work that we do. If so, we are eager to make a connection with you and to continue to grow our network. It helps us achieve our goals and our work. I heard actually a lot of consensus here today. I heard a consensus on urgency and urgency for action in particular. I heard a consensus on the imperative to prioritize diversifying our workforce. And I too want to acknowledge and thank the Health Equity Compact and the leadership there. And thank you, Michael, for holding us to account to our goals and values when it comes to health equity. I heard a consensus for better data and evidence to be able to track and understand these trends. That's something that we will be working on with Director Peters at CHIA. I heard a consensus for opportunity and collaboration and for partnership. And I heard a consensus for a need for bold rethinking, whether that's a moonshot or breaking the cycle. We at the HPC are enthusiastic about continuing this work in the healthcare workforce space through our role as a convener, as a partner, as expert researchers, and as a listener. Because this challenge is critical to our foundational goals of access, quality, equity, and affordability. Finally, I want to thank the healthcare workers and caregivers in Massachusetts. Thank you for your dedication to providing compassionate care to our residents, families, and loved ones. And we look forward and are committed to supporting you as you have supported all of us. So thank you, everyone. Have a great day.